From the time they are born, children with cleft lip and/or palate face many challenges. They struggle to eat, breathe, speak, and even survive. Treating cleft lip and palate requires a range of long-term, comprehensive cleft care interventions. But around the world, there is a severe shortage of medical professionals with the skills or resources necessary to provide this specialized care. This is why SmileTrain, as part of our sustainable partnership model, offers a variety of innovative training and educational resources to cleft care providers around the world. For over 21 years, we have partnered with cleft care professionals at more than 1,100 hospitals in over 90 countries, offering more than 40,000 training opportunities, a number that is growing every day. Over the coming years, SmileTrain will scale these programs and resources because we know that behind every smile, there's a team of healthcare professionals who made it happen.
Maraming challenges rin na pagdaanan ko. Nandiyan yung tinutuksokan, yung bata ka. Siyempre nasasaktan ka, di ba?
Hindi ko sila lang sinasabi kay mama, pero may times na binubuli pa rin ako. Halos araw-araw yun, pagpapasok ko sa school. Tapos nasa rin ka nila ng bingot, gano'n. Tapos halimaw.
Mga classmate mo, ina-assert mo ako. Hirap mo minsan, ina-assert mo ako. Mananalalasert mo ako, tinatawanan mo ako.
Nung baby na po ako nilang parang i-opera po ako. Akala po nila parang, mamamatay na nun po.
In the Philippines, there are about 5,000 babies born with a cleft lip and/or palate annually. Cleft is far more than a cosmetic problem. Children with untreated clefts not only live in isolation, but also face physical difficulties with eating, breathing, and speaking. As a result, most of them don't attend school or ever hold a job. Cleft repair surgery is safe and the transformation is immediate. SmileTrain is the world's leading cleft charity that supports comprehensive cleft care, including surgery, orthodontics, dental services, speech therapy, nutrition, and psychosocial support. SmileTrain's sustainable model focuses on training local medical professionals in more than 90 countries to perform cleft repair surgery and comprehensive cleft care in their own communities. They then go on to train others, creating a long-term, sustainable system.
Kung hindi ako na-operahan, siguro baka wala ako dito ngayon. Baka nasa bahay lang ako, nagtatago.
Magiging normal na rin yung buhay ko, yung wala nang manlalait sa akin.
Masaya po, maayos-ayos ako yung makakapunit ko kanina po dati.
Ngayon po, nakakangiti na po ako. Natutunan po ng SmileTrain.
Cleft repair surgery may take as short as 45 minutes, but the impact is life-changing. Former patients have the opportunity to attend school, get a job, start a family, and contribute to the society at large. Refer someone in need today and give the gift of a smile and a second chance at life.
From the time they are born, children with cleft lip and/or palate face many challenges. They struggle to eat, breathe, speak, and even survive. Treating cleft lip and palate requires a range of long-term, comprehensive cleft care interventions. But around the world, there is a severe shortage of medical professionals with the skills or resources necessary to provide this specialized care. This is why SmileTrain, as part of our sustainable partnership model, offers a variety of innovative training and educational resources to cleft care providers around the world. For over 21 years, we have partnered with cleft care professionals at more than 1,100 hospitals in over 90 countries, offering more than 40,000 training opportunities, a number that is growing every day. Over the coming years, SmileTrain will scale these programs and resources because we know that behind every smile, there's a team of healthcare professionals who made it happen.
Maraming challenges rin na pagdaanan ko. Nandiyan yung tinutukso ka, nung bata ka. Siyempre ikaw, nasasaktan ka, di ba?
Hindi ko sila lang sinasabi kay mama, pero may times na binubuli pa rin ako. Halos araw-araw yun, pagpapasok ko sa school. Tapos nasa rin ka nila ng bingot, gano'n. Tapos halimaw.
Mga classmate mo, ina-assure mo ako. Ina-assure mo minsan, ina-assure mo ako. Mananalahat mo ako, tinatawanan mo ako.
Nung baby na po ako po nilang parang i-opera po ako. Akala po kami nila parang, mamamatay na nun po.
In the Philippines, there are about 5,000 babies born with a cleft lip and or palate annually. Cleft is far more than a cosmetic problem. Children with untreated clefts not only live in isolation, but also face physical difficulties with eating, breathing, and speaking. As a result, most of them don't attend school or ever hold a job. Cleft repair surgery is safe and the transformation is immediate. Smile Train is the world's leading cleft charity that supports comprehensive cleft care, including surgery, orthodontics, dental services, speech therapy, nutrition, and psychosocial support. Smile Train's sustainable model focuses on training local medical professionals in more than 90 countries to perform cleft repair surgery and comprehensive cleft care in their own communities. They then go on to train others, creating a long-term, sustainable system.
Kung hindi ako na-operahan, siguro baka wala ako dito ngayon. Baka nasa bahay lang ako, nagtatago.
Magiging normal na rin yung buhay ko, yung wala nang manlalait sa akin.
Masaya po, maayos-ayos ako yung mukha ko, hindi po kanina po dati.
Ngayon po, nakakangiti na po ako. Nakakano po ng Smile Train.
Cleft repair surgery may take as short as 45 minutes, but the impact is life-changing. Former patients have the opportunity to attend school, get a job, start a family, and contribute to the society at large. Refer someone in need today and give the gift of a smile and a second chance at life.
Hey, good morning, good afternoon, and good evening to everyone here today. My name is Kimi, and I look after Smile Train's work in Southeast Asia. We understand that this two-part webinar asks for a significant amount of your time and commitment, and for that, we are truly grateful. This collective effort from everyone here today is a reinforcement of how important this topic is for all of us involved in providing cleft care. I am happy to share a message from our head office with you. Please welcome Ms. Grace Peters, Smile Train's Program Associate for Comprehensive Cleft Care.
Good afternoon to all of our partners who are with us today. It is truly an honor to speak before you and highlight Smile Train's work around addressing malnutrition in infants born with a cleft. If you were able to attend the first webinar on feeding and nutrition held last December, welcome back. I know you will find this discussion extremely valuable as well. Thank you again to Dr. Silvestre of KMI who put all of this together. Smile Train is grateful for the opportunity to be working with you and your team to advance cleft nutrition, not just in the Philippines, but across Asia and around the world. As you know, Smile Train, through our local partnerships, strives to provide the continuum of care that an individual born with a cleft requires to live a full and healthy life. Some of you may be familiar with Smile Train's recommended comprehensive cleft care timeline that was developed by members of our Global Medical Advisory Board and with input from our regional medical advisory councils. In case you're not familiar with this recommended timeline of care, you can access a copy of the timeline on Smile Train's website. The goal of this global resource is not to dictate exactly how partners or regions provide care, but to move all partners towards offering the safest, highest quality, and most timely comprehensive cleft care. One of the many very important and life-saving aspects of this comprehensive cleft care timeline is feeding and nutrition, which includes addressing malnutrition in infants and children. We know that achieving our vision of a world where every person has access to safe, high-quality, comprehensive cleft care and is able to live a full and healthy life requires inclusive nutrition programs that support mothers and babies impacted by clefts. Our nutrition programs have been expanding over the years, led by people like Dr. Silvestre and local Smile Train medical partners around the world. Children are disproportionately vulnerable to the impacts of malnutrition because it's happening at a time in their development that will define their entire life. The nutrition that children receive during the first 1,000 days of life and throughout their development has a permanent impact on their physical growth and their mental development, and subsequently on their education and their future economic opportunities. In September of 2021, during the United Nations General Assembly, Smile Train announced its 5-year commitment to scaling our investment in global nutrition. In order to achieve these commitments, Smile Train has continued to train and educate healthcare workers on feeding counseling to patients and families impacted by clefts, decentralized our grant process, started tracking height and weight measurements in Smile Train Express, our medical database, created more nutrition resources for partners and families, and so much more. With your partnership and with your support, we will be able to achieve these goals. Thank you to our panelists of experts for taking the time to share your experiences and your knowledge with our partners here at this conference. We are so proud to be working with all of you to provide optimum cleft care for tens of thousands of babies born with cleft across Asia. I hope that we can all gather in person again sooner rather than later. But in the meantime, please stay safe and enjoy this discussion. Thank you so much.
Thank you, Grace. And allow me now to share just a few slides about what Grace has shared in her talk. Okay, so as you know, children born with a cleft face many challenges, and the first among these would be feeding and nutrition. We are grateful to be working with passionate individuals and organizations who have made it their life's work to ensure that no child gets left behind. With your help, babies born with a cleft can receive the safe, quality, and timely care they need. I'm happy to share the story of baby Jay, who you see on the screen today, who has a complete unilateral cleft lip and palate and came to us severely underweight, unable to breastfeed, and was anemic. With the help of our nutrition partner, Dr. Marge Shibayan, you see in the second photo on the screen, we were able to provide baby Jay with his surgery recently. Now, Grace referred to Smile Train's comprehensive cleft care timeline, which you may access through our website as shown on this slide. This is only one of the few important resources you will find on our site, so please take the time to visit and check out other available materials related to comprehensive cleft care, and you will find these in multiple languages as well. I'm also happy to elaborate on Smile Train's commitment presented at the United Nations General Assembly held last September 2021. So by the end of 2026, through awareness campaigns, advocacy, program expansion, partnerships, training and education of health workers, Smile Train's increased investment in nutrition will result in more than 1 million mothers and children benefiting from cleft-specific feeding counseling, more than 55,000 child malnutrition cases averted, over 40,000 educational opportunities on cleft feeding and nutrition, such as this one, more than 1,000 partner hospitals across 70 countries empowered to offer nutrition services to every mother and child there affected by cleft, over 250 partner hospitals in an organized network offering advanced nutritional care for malnourished children affected by cleft, and a 40% reduction of the number of stunted children undergoing cleft surgery. Now, thank you to all of you who are and will be instrumental in achieving these commitments. Smile Train continues to create impact all over the world and will continue to work tirelessly to ensure that cleft-affected individuals and their families all over the world receive the support they need. I would like to turn over the mic to my colleague, June Grimares, Program Director for Smile Train Philippines, who will now introduce our panel of speakers.
Thank you, Kimi, and good afternoon, everyone. Before we proceed, I would like to remind everyone that questions are welcome and will be addressed during the open forum. Kindly type in your questions in the Q&A box that you can find at the bottom of your screen. And now I would like to introduce to you to our esteemed panel of speakers. First, I would like to introduce to you Dr. Mian Silvestre. She is the founding president of Kalusugan ng Mag-ina, for the health of the mother and child. Founded in 2010, KMI is a nonprofit dedicated to the health of the mother-child dyad. With support of UNICEF Philippines, KMI has been contributing significantly to the Philippines Department of Health capacity building efforts for the Philippine Integrated Management of Acute Malnutrition, or PMAN. The design of the National Health Insurance Special Benefit Package for severe acute malnutrition and the Z Benefit Package for preterm and low birth weight babies. She's a pediatrician with advanced training in pediatrics, in neonatal perinatal medicine at the Children's Hospital of Michigan and Hudsell Hospital of the Detroit Medical Center in Wayne State University, also in Michigan. Our second speaker is Dr. Donna Capili, a pediatrician and neonatologist. She's trained in neonatal and perinatal medicine with the University of Toronto, Faculty of Medicine, Division of Neonatology. However, coming back to the Philippines, she found herself more immersed in the value and practice of population based on preventive health care and eventually switched her course into public health. Among her endeavors was her contribution in the development of the training course for the Philippine Integrated Management of Acute Malnutrition in Children. And finally, our third speaker and today's moderator is Dr. Andrew Buku, a medical doctor by training. Dr. Andrew started his career in public health in disaster preparedness and emergency response, such as recovery and rehabilitation efforts for typhoons and other complex emergencies in Mindanao in southern Philippines. This proved to be a fateful encounter, as this was also the time when community-based management of acute malnutrition, CMAM, was introduced to the Philippines. Since then, he has worked with UNICEF and with the Department of Health to adopt and develop CMAM into the Philippine Integrated Management for Acute Malnutrition program and help scale up program implementation and training across all 17 regions of the country. As an independent consultant, he continues to work in CMAM as one of his personal advocacies and still look forward to the day when PMAM will be accessible to all as a step towards zero malnutrition. Smile Train would like to thank all of the speakers for their time and dedication to helping children in the Philippines and around the world with the work they do. I would like to turn you over to our moderator, Dr. Buku.
Thank you very much, June, for the kind introduction. Really, the honor is ours. Before we start, we'd like to give a special thank you to Smile Train for making this opportunity happen. It's always so very nice to have this opportunity in it when organizations are able to align their advocacies for each other. And this is a great opportunity. Personally, it's a bit overwhelming because firstly, we'd like to welcome everybody who's come in for this webinar. We were a bit surprised by the participants who have registered. We have over 300 participants who registered from nearly 20 countries. So this is a great opportunity for us to be able to share our our knowledge on the topic of community-based management of acute malnutrition. So in the interim that we're waiting for the preparations for our first speaker, we just like to remind everybody on a few house rules. So as June mentioned earlier, we will be having an open forum at the end of all the lectures. This is, of course, in the interest of time. So while we would have wanted for this to be a more dynamic and interactive discussion, in the interest of time, we have to take all of the questions as a whole in the open forum at the end of the session. But in the interim, if you do have any questions, please feel free to utilize the Q&A tab at the bottom for any questions. Please feel free to type it at any time. And throughout the lecture and also during the open forum, we will be finding time to address your questions. As much as possible, try to use this particular tab and not the chat function. If you use the chat function, there's a tendency that there's a bigger possibility that it might be overlooked because of the many messages coming in through the chat. So please try to use the Q&A function for your questions. And lastly, for any throughout the lecture, throughout the session for today and tomorrow, we will be having some poll questions that might be popping up on your screen. So we kindly ask for you to participate in these poll questions. When these come up, as you can see in the right-hand side of the screen, there will be just a few questions coming up. This is just a sample question, but when it comes up, please select your answer and don't forget to press submit, and then for us to be able to record your answer, and this will add to our discussion. So with that, also by the way, if there's anybody who has not answered the pre-test, please don't forget to also answer the pre-test, just in case anybody has missed out on that. So I think that's enough time for an introduction. That's enough time that I bought enough time for our first lecture for today. She actually needs no introduction because she's very well known, not just in the Philippines, but also across the world as one of the champions for malnutrition, not just for children, not just for mothers, but actually for everybody. And she's the founder of Kalusugan ng Mag-ina. And we're very lucky for this opportunity, to have this opportunity for her to share her knowledge with us this afternoon. So without any further ado, we'd like to welcome Dr. Maria Asuncion Silvestre.
Magandang hapon, as we say here in the Philippines, and good afternoon or good evening, good day probably to our participants from the 19 or so other countries in the world. We are so overwhelmed that you have come in droves, so to speak, to be with us this afternoon here. Thank you, Grace. Thank you, Kimi. Thank you, June. Thank you, Drew. KMI, or Kalusugan ng Mag-ina, is very honored and grateful also to be able to participate in what we feel is a very, very important, very relevant, and a very timely webinar for all of us, regardless of where we are in the world. So I'm just going to dive in so that we can tackle more ground. Next slide, please. We always want to start our webinars with a disclosure statement, and this will serve as a disclosure statement for all of us 3 speakers during these 2 half-day sessions consisting of our webinar. Just to introduce KMI briefly, our mission, as our name implies, is to promote and protect the health of the mother and child dyad. We are not able to provide direct services, whether humanitarian or not, but we do so. We try to promote and protect the health of the dyad through research, policy development, capacity building, and program implementation towards our vision, like I'm sure all of us here, of eliminating preventable causes of deaths of mothers and their children, and hopefully to contribute to all efforts to allow every mother and child to attain their highest attainable state of health. With our mission and vision in mind, I and my 2 co-speakers, our technical experts, declare no financial relationships with the manufacturers and or distributors of 2 groups of products known to be harmful to mothers and their infants. These are tobacco products and any breast milk substitutes, so to speak, or baby foods, nor any other product covered by the Executive Order 51 our national law, which is nicknamed the Philippine Milk Code. Next slide, please. Some of you may have attended our webinar 1, which was held in 2 half-day sessions in December of last year. Those 2 webinars are actually available on the Smile Train program's YouTube channel for free. We will probably send you the links tomorrow after we end, or even this afternoon after we end this webinar. In that first webinar, we discussed specialized breastfeeding counseling for infants with clefts made practical. And like in the first webinar, this webinar on acute malnutrition, we hope, even if it was targeting infants with clefts, we hope that you can have broad applications to screening, triage, and referral for acute malnutrition in the general population and not just for the target population of infants with clefts. Next slide, please. Okay, so at the end of my short session, I hope the learners will be able to, 1, discuss acute malnutrition, its prevalence in children with clefts, the associated risks of acute malnutrition in these children, and the need, and for why we are here this afternoon and tomorrow afternoon for screening for acute malnutrition in general. Next slide, please. Okay, in the first webinar, we went over these slides quite quickly. I'd like to repeat these slides on information just to drive home why what we are doing now is significant and why we need to know these things, these important relevant matters pertaining to infants or children with clefts, okay? The worldwide prevalence of cleft lip and or cleft palate, we are terming that CL/CP. The worldwide prevalence is between around 1 to 3 per 1,000 live births, okay? Among all of these children with cleft lip and or palate, the most common, or about half of these children, have both cleft lip and cleft palate, okay? Maybe about a third have an isolated cleft palate, okay? And about 1 in 5 have an isolated cleft lip, among whom the cleft lip, the defect may extend to the alveolus or the dental margin, okay? There are differences in prevalence across races and geographical areas, with the lowest reported prevalence being in the African continent at maybe 0.5 or not even 1 per 1,000 live births. But the highest in Native Americans, about almost 4 per 1,000 live births. And in the majority of our participants in this webinar, in Asian populations, about 2 per 1,000 live births. So it is a significant congenital or inborn anomaly, so to speak, or deformity that afflicts many of our families. Next slide, please. Okay, so for the general group of cleft lip / cleft palate, the most common are one-sided or unilateral, but the cleft lip or palate can also occur bilaterally. As you see in the picture here, many of our pictures were contributed by mother support groups all across the Philippines. This one in particular contributed by Lizlie Pasqua of Breastfeeding Bicolanas, mother support group of breastfeeding peer counselors in Region 5, the Bicol region, okay? Most of these cleft deformities are isolated clefts, and most are also born full term. So it's not as common that babies with clefts are born prematurely or too early, okay? The majority of these clefts, of these isolated clefts, are what we call non-syndromic. So they do not occur as part and parcel of a congenital syndrome. For example, what you have listed here, the DeGeorge sequence or syndrome, the Pia-Roban sequence, the chromosomal deletion syndromes or Van der Waal syndrome. The clefts that occur as a component of a syndrome or multiple congenital anomalies, so to speak, occur in only about 1 in 3 of all these patients with cleft lip or palate. So the non-syndromic isolated clefts are more common, and they are more commonly full term also. Next slide, please. Okay, so we show these illustrations, very important illustrations, courtesy of Aidan Farrow, which I am using here from the Academy of Breastfeeding Medicine Clinical Protocol 17 that was revised in 2019 and included in Dr. Ruth Lawrence's 2022 textbook. So this worm's eye view, so to speak. So the view from below of a completely formed lip and palate. So these are the structures, the nose, the columella, the partition between the two sides of the nose, the philtrum, the space between the nose and the mouth and the lips. The lip, of course, the incisive foramen, which is the midline point where the opposite sides of these bony structures fuse. The gum and alveolus, the hard palate, or in the Philippines called ngalangala, and the soft palate, which is the smooth muscular layer behind the hard palate, which extends into the bell-shaped uvula that projects midline that you can see in the back of your mouth. Okay, so which leads eventually into your throat, or what is called the pharynx. So this is the normally or completely formed lip and palate. Next slide, please. Clefts of the lip can occur either unilaterally, as you see in illustration B, or bilaterally, as you see in illustration C. Same source, but you can imagine how these defects in the lip, whether unilateral or bilateral, can result in difficulties in attaining a good seal that is required for attachment or latching on. And these can lead to feeding difficulties and or lactational insufficiency. Okay, and after which many mothers who are not properly counseled will resort to bottle feeding of formula and the resulting undernutrition when these feeding practices are suboptimal. Okay, so next slide, please. This is an illustration of unilateral, okay, and bilateral or two-sided cleft lips, okay, in these two children, again, from the Bicol region. Next slide. And it's very easy to imagine that these problems associated with these physical defects in the lip and or palate can lead to not only feeding difficulty, but also breathing difficulty if these young infants, newborns even, aspirate or choke on the milk that regurgitates up their nose, their nasal passages. And of course, since the upper nasal passages and the middle ear are connected to eventual hearing disorders, of course, with the defects in the palate, you have speech disorders that eventually can lead to permanent hypernasal speech, okay? And of course, later, physical and social development, multifaceted problems with the physical and social development of these children if surgical repairs are delayed. Next slide, please. So in the first webinar, we went over some of the recommendations of the Academy of Breastfeeding Medicine, which were evidence-based, okay? Foremost of which is that we should, despite the presence of these deformities at birth, we still should encourage the parents to breastfeed and provide breast milk whenever possible. So in that first webinar, we illustrated how hand expression of breast milk can be done, again, from Breastfeeding Bicolanas, how hand expression can be done, collected into a cup, stored if necessary, and provided to the infant who might be still separated from his mother. Next slide, please. We also had topics on how exactly What are some of the practical skills that one might need to help a mother attempt breastfeeding so that her supply of breast milk is maintained despite the difficulties, no? We talked about that in the first webinar. And of course, to promote the very important, very protective bonding that these babies really need in the face of these difficulties. Next slide. This is our cutie pie baby here, who we also taught in that first webinar. You see here our partner in Mindanao, Nadine Casino of Modern Nanays of Mindanao, contributed this picture of a baby being fed by Nifty Cup, no? And the Nifty Cup also, we have videos of the use of the Nifty Cup in that webinar, contributed by another partner, Dr. Marge Sibaya. Next slide, please. A whole network of mother support groups contributing towards these efforts all across the country. The important recommendation B is that this assessment and support has to be timely. So we see here another picture of the timely intervention on this infant by Breastfeeding Bicolanas. And here we have Marife Dia, who was able to track the family of this baby, next slide, and get the baby into surgery, okay, despite the fact that the baby looked underweight. Fathers are also involved here, even with the specialized breastfeeding counseling techniques required. Fathers are definitely in the equation or in the formula, okay? So here we see a father, this is contributed by Dr. Sibayan again, confidently using a Nifty Cup to feed this baby with cleft deformities of the lip. Next slide, please. Okay, and another, this is a post-surgical infant here already, as early as a day after the surgery. They can already be fed by cup, and this is breast milk. You can see from the color itself that this is breast milk. Next slide, please. Okay, so there were what I already mentioned are clinical strategies or implementation strategies in the clinics, no, to support these mothers. Next slide. In webinar 1, we also talked about national strategies or programmatic strategies. We talked about unang yakap or the first embrace at birth, what we can do to help these mothers, no? But even before that, in the antenatal period, how to counsel the mothers on how to prepare for an unang yakap or the first embrace delivery. We talked briefly also about kangaroo mother care programs for the low birth weight infants, whether they're born with cleft or not. We also talked about the network of human milk banks that are existent now and functioning in the whole archipelago, and supported by our network of mother support groups that are helping mothers provide this life-saving breast milk, even in the face of separation from their babies with clefts. Next slide, please. Okay, so to reiterate, infants with clefts, even from birth itself, commonly face difficulties with breastfeeding that in turn put them at risk for undernutrition, okay? And with that comes maybe repeated infections, delayed surgical repair, and compromised psychosocial and physical development arising from the delayed surgical repair. Skilled breastfeeding counseling by trained mother support groups, okay, provides a crucial service, okay, a crucial care at the right place and time, and can spell a world of a difference for these babies. And this is what we are trying to push further. Without this timely breastfeeding support, they are at high risk to become acutely undernourished, and we're going to talk about that for the rest of the sessions today and tomorrow. Next slide, please. Because this inordinate risk carries with it, multiplies even the risks of formula feeding in and of itself. And we do not have time to go over these harms to both the infant and the mother in much detail in this webinar, but this is why we are going full blast into helping mothers breastfeed. All the more, breastfeed infants with clefts because these harms carry lifelong risks for both the mother and the baby. Next slide, please. We started last time with the story of Ralph, who was referred to the mother support group at 7 days of age, okay? But unfortunately was lost to follow up because the system, maybe the health system at that time did not support her needs as a high-risk family with an infant with cleft. She moved to Metro Manila, which is where we all are, at least KMI is. And in the urban center, she started her baby mistakenly on infant formula. Okay, next slide, please. The baby subsequently returned to the Bicol region, but returned undernourished because of the expensive formula and suboptimal feeding practices contributing to dilution of the formula, and the undernourished state, of course, delayed the cleft surgery, okay? Because breastfeeding Bicolanas was able to reestablish contact, breastfeeding Bicolanas referred to the provincial nutritionist, rapid weight gain was restored and the repair was done. After the repair, IYCF, or infant and young child feeding counseling, was continued, and breastfeeding Bicolanas together with the government health authorities are still following up baby Ralph. Next slide, please. We want this story to be duplicated, okay? But this story can only be duplicated if we have more health workers, more community members and families able to recognize acute malnutrition or wasting when it is there, okay? Global incidence of acute malnutrition or wasting is about 7.7% in infants under 5 years of age, 2.5% of which have severe acute malnutrition. And as we'll learn later, this affords a 9 to 12-fold increase in dying, okay? Cleft lip and palate or surgical procedures have, of course, the need for proper wound healing, and especially the hypermetabolic state of the post-operative period requires cautious nutrition. Impaired post-op feeding will result in higher complication rates. Next slide, please. This is the prevalence we used. We reviewed the cross-sectional analysis of Smile Train's global database spanning 10 years by Delage and her co-workers. They had 602,568 subjects after exclusions from 60 countries, most of which, the majority of which were from Southeast Asia, with 3 in 5 having both cleft lip and palate, with 1 in 5 having only cleft lip and 1 in 5 only cleft palate. What did they measure? They measured weight for age Z-scores, or what we call underweight. Next slide, please. Okay, what we found was delayed. A very common occurrence of delayed surgery for cleft lip only, a median of 8.5 months, where it should be only 3 months. Cleft lip palate, 10.5 months, where it should be round about 9 months, and for cleft palate only 20 months. Okay, there were no sex differences between the rate of late surgery, but there were regional differences in late surgery for cleft lip, with Southeast Asia, our continent, and Africa having the highest rates of late surgery after 1 year. Next slide. Malnutrition as a risk factor for cleft surgery was studied in a retrospective review of 855 children undergoing their initial surgery or their revision surgery. And they studied again weight for age, but also height for age Z-scores. Next slide, please. And they found that for cleft lip and cleft palate, there were high rates of either moderate chronic or at least moderate acute malnutrition in both these groups. Next slide, please. Okay, they also concluded that improving the nutritional status from their data improving height for age predicts a decreased risk for fistula formation after cleft palate surgery, and that chronic malnutrition or stunting significantly increases the risk of fistula formation. Okay, so abnormal channel between the repaired sites. Okay, pre-op strategies are important to manage or to mitigate this risk of fistula complications. Next slide. Okay, so as that introduction, this is what we have in store for the next few hours today and tomorrow. Next to me, there will be an overview of acute malnutrition. Then Dr. Drew will go over how to identify acute malnutrition. And tomorrow we will go over these other topics. Next slide, please. Okay, references for my talk are these. If you're very interested, you can just quickly take a screenshot. But thank you for your attention, and I'd like to turn over the floor now to Dr. Drew. I'm sorry, to Dr. Dr. Drew to introduce Dr. Donna. Thank you.
Thank you very much, Dr. Ramian, for this lecture. As we can see, it's very clear that it's a very good overview in terms of the advocacies that we both have in terms of cleft lip and cleft palate, and also for malnutrition. And as we can see, there's plenty of room for collaboration, especially since we all want the same thing, basically, that we want to address these problems in the most timely and the most comprehensive manner. And it's a very exciting time. It's a very timely webinar to have, so that we can hit two birds with one stone, basically. So from the lecture of Dr. Ramian, we now jump over to having a lecture as an overview of malnutrition. It's important for us to also to be able to appreciate the overall picture of malnutrition in order for us to be able to properly address the problems of our patients and our children. So our next speaker is just a brief background, actually, for on the work that Dr. Ramian in the previous has done. Both of them were involved in the development of the guidelines for the Philippine Integrated Management of Acute Malnutrition. They were very instrumental in developing the training modules and have been also participating in the rollout. This next person in particular is technically the technical expert for everything that we went through. If there were any questions, she was the go-to person to clarify all these things, especially because of her vast experience in terms of managing neonates and children, basically across from her experience in managing children. So I can see that she's smiling right now, but this welcome is very much just up for you, Doctora. So without further ado, we'd like to introduce Doctora Donna Isabel Capili for our next lecture.
All right. Thank you, Dr. Drew. I'm afraid of what you had just done. Anyway, but thank you for that introduction. I don't know if I deserve all that, but I just hope my only goal is that for this next maybe half hour or so is that I am able to achieve my learning objectives for this particular talk. Next slide, please. So basically, this first lecture is really just to level off when it comes to concepts about undernutrition. And what we aim is really to ground ourselves to what's happening when it comes to malnutrition in our communities, and how it has really been neglected as a public health issue, so much more now with the COVID-19 pandemic. Even before this all happened, we were already doubting how much of a silent pandemic undernutrition is, or malnutrition is. And the consequences have been quite dire, especially for our children. Okay, so next slide, please. So let me first showcase to you this video, and bear with me. I will speak over it as it has been originally dubbed in Filipino. So let's play the video. So the title is Hunger, or Gutom. So this actually narrates about a day in the life of 7-year-old Jasmine, who's from the Bicol province, and she's asking for money from her mother, and the mother's asking, "What do you need money for?" But the problem is There's no money, and Jasmine is hungry. And so we can see her in tears here. And this video, we actually made this back in 2016. At this time, 3.1 million Filipino families experience hunger. Now with the pandemic, it's actually 7.6 million Filipino families. And this is largely borne about by poverty, by the lack of access to responsive and appropriate caregiving, as well as the lack of access to appropriate care or to healthcare services. And because of this undernutrition that results from these factors, how will children like Jasmine survive? Right? Paano tayo mabubuhay? And so now here she's being asked by the interviewer, why are you crying, Jasmine? Why? And so here we see her that she's just taking sips of water just to tide her hunger over. And she's being asked, what do you do if there is no food for you to eat? And so she's saying that what she does is to drink that cup of water. So it's been estimated that 5.5 million Filipino children are actually undernourished. And these are children who are aged 0 to 10 years. Sorry for that small technical glitch, but I think we can move forward with the next slide. Alex, great, thank you. So pretty much when we showcase this video and when we do face-to-face trainings, we would normally ask our participants, what does that make you feel? And usually they'd say that they're very sad or that it feels like a helpless, hopeless situation. But the thing is, we shouldn't feel helpless nor hopeless. We're part of the healthcare system and we're here to do something about it. And this is exactly why we're all here, particularly so for us who are caring for children with clefts. And the implication is if there's a lack, and you saw that from Dr. Mian's own lecture, you saw that with the lack of appropriate support for nutritional upbuilding, these children will just fall prey into that vicious cycle of undernutrition and therefore poor health and potentially increased chances for morbidity and mortality. So the learning objectives for this session is to explain what malnutrition is and its related concepts, to discuss the problem of childhood deaths due to the various forms of malnutrition, acute malnutrition, in this case, moderate and severe acute malnutrition. We will also go over the global and then also the Philippine Plan of Action for Nutrition, or what we call here PPAN, on acute malnutrition. And we will also describe the Philippine Integrated Management of Acute Malnutrition, or what we call here as PMAM. So as you can see, there's a lot of acronyms here. And then we will segue into the 4 guiding principles of PMAM and then to the 4 components of the integrated management of severe acute malnutrition within PMAM. So next slide. I think we all agree that each child has the right to food, health, and also the appropriate care so that we are enabling the development of their optimum potential. And lack of any of these factors would risk the development of malnutrition. And we will establish that malnutrition is strongly linked with death. Next slide, please. So what exactly is malnutrition? Basically, it's an imbalance. It's an imbalance between the body's dietary or food intake at its very core. And this intake then fails to maintain healthy tissues and organ function. So when we talk about malnutrition, it's actually either overnutrition or undernutrition. But for these 2 afternoons, we are going to focus on undernutrition. So next slide, please. So when we talk about undernutrition, there are various causes, and so at so many different levels. There are societal causes, levels of the community. There would be causes that we will find there underlying the causes for undernutrition, and also at the individual level. We need to be well acquainted with this, particularly us in healthcare. We shouldn't just be concerned about patients who come in and just look at them and see that they are thin, but rather we should start questioning ourselves. Why is this child underweight? Why is this child thin? And then we will uncover the many different causes. No, this is not to say that we will be able to address single-handedly societal causes, but this is more of a cue for us to then work across sectors and find solutions for these underlying causes of undernutrition. Next slide, please. So we talked about causes, but let's look at the cycle of malnutrition and disease. No? So if you train your eyes over to the left-hand side into that circle, you have inadequate dietary intake, which is the very basic when it comes to undernutrition. So if a person doesn't eat well enough or is somehow restricted in the way he or she takes in food, then this person, without support or help, will become thin, no? Will experience weight loss. And with that, if that doesn't become abated, well, then there would be resulting growth faltering and will also render that person susceptible towards lesser immunity as well. And with that, this person will then get into the process of getting more sick. No? So this is then going to the circle on your right-hand side. So there's increasing, this person will contribute, and many others like him or her will contribute then to the increasing incidence of disease as well as severity and duration, right? And therefore, this person who is not eating well, whether it be a shortage of supply or the inability itself to digest the food or eat the food or take the food, therefore, this person's own metabolism will change in response to that, right? And as we probably have all experienced, when we get sick, our appetite also gets affected. We lose our appetite. And therefore, that doesn't help at all. So this pernicious cycle will continue. And it will continue on unless there is an intervention at any of these stages to rectify the situation. Okay, next slide, please. So I said earlier, we're going to focus on undernutrition for these 2 afternoons. So let me just go over with you the types of undernutrition. First, as is our focus, is acute malnutrition or sudden wasting and or edema. And just to reiterate again, the factors may be due to insufficient food intake. It could be to recurring infection or just one really bad infection, as we would see, no, with patients that get admitted in hospital for protracted periods, and their appetites are affected, as we had seen in the previous slide. And then there's also inappropriate childcare practices. There may be cultural beliefs that will push for a month-old baby or not even to get started on table food, and therefore missing out on the benefits of exclusive breastfeeding. So when we talk about acute malnutrition, this is diagnosed when there is a child presenting with a low weight for height or a low weight for length. We'll get to distinguish when to take height or length in the 3rd lecture or in the lecture after me on measurements. It's also diagnosed when there's inadequate weight for age and or muscle wasting and or bilateral pitting edema. Next slide. So acute malnutrition is what we've termed to be wasting. So there are actually 2 types. There is moderate acute malnutrition, or MAM, or moderate wasting. And then there's severe acute malnutrition, or SAM, or severe wasting. Let's not go over the nitty-gritty of the measurements. As I said, that lecture is following after me. I think what we want to point out, next slide, please, is global acute malnutrition, or GAM. GAM is actually the sum of the prevalence of SAM and MAM at the population level. And it's a good indicator to follow, because this is a reflection of what the health system is doing in as far as supporting the needs of the children, in as far as nutrition is concerned. Okay, next slide, please. So severe acute malnutrition, as we had mentioned 2 slides back, It encompasses wasting and bilateral edema. For those of you who are old school like me, we probably know it also as marasmus, which refers to severe wasting, as is illustrated by that picture on your left. And then there's also kwashiorkor, which refers to nutritional edema. They don't look wasted, but they are bloated. And this is severe acute malnutrition. And both types, whether it be severe wasting or those who are bloated up with nutritional edema, these types can actually kill. Children with severe acute malnutrition are 9 to 12 times more likely to die than well-nourished kids. So don't be deceived. Next slide, please. So moderate acute malnutrition, even though we say it's moderate, doesn't mean that it won't bring any harm. But before we get into that, moderate acute malnutrition is wasting, but there's no bilateral edema. Okay, so children with moderate acute malnutrition, they are also at risk of death. Children with MAM are 3 to 4 times more likely to die than well-nourished kids. Next slide, please. So here we can see the situation in the Philippines. This is as of the 2019 National Nutrition Survey update, that 5.7% of children less than 5 years of age are wasted in the Philippines. That is, either they have MAM, which is 4.6%, or SAM, which is at 1.1%. So this accounts for nearly 700,000 Filipino children, but this was pre-pandemic. So we don't have the numbers after and during this pandemic. Rather, it's still ongoing. So next slide, please. So for severe acute malnutrition, the case fatality rate is 4.4%. And we've already highlighted the fact that children with SAM are 9 to 12 times more likely to die than well-nourished kids. What about MAM, or moderate acute malnutrition? The case fatality rate is higher, 10.2%. And this is because the absolute number of children with MAM is higher than those with SAM, right? So they would have a higher case fatality rate. And we'd already mentioned earlier that children with MAM, even though it says moderate, and we shouldn't be deceived by that adjective as well, they are at risk of dying as much as 3 to 4 times than well-nourished infants. Next slide, please. Okay, next slide. All right, so we're talking about types of undernutrition. We've said a little bit about acute malnutrition. So now we're going to talk a little bit about chronic malnutrition, or what we also know as stunting. So stunting is being too short for one's age. So it's inadequate height or length for age. And stunting has become such a big thing in our agenda. Prior to the pandemic, there was much focus on stunting and how we can rectify the situation by putting the spotlight on the first 1,000 days. And this would be elaborated on further in a few lectures after me, or perhaps tomorrow. But stunting that happens before the age of 2 is really irreversible, and it is associated with poor cognitive and educational outcomes, and the mental and physical deficits that occur with it could be potentially irreversible beyond the age of 2 years. Just as a note, we always say this, but stunting is causing 3% of our gross domestic product in the Philippines every year. And Typhoon Yolanda had created that same dent. The COVID-19 pandemic has dented us in as far as 9.1% of our gross domestic product. And then you add, the repercussions coming from stunting. So this is really also something that we should be acting upon as well. Next slide, please. So we've talked about types of undernutrition, acute malnutrition, chronic malnutrition, and now let's acquaint ourselves with micronutrient malnutrition. So micronutrients, as the word implies, these are nutrients that we require in small quantities in our bodies, and deficiencies could lead to malnutrition and disease. So if you look at the photo on your right-hand side, this is actually a manifestation of vitamin A deficiency, of ophthalmia, or what we also call as keratomalacia. Okay, next slide, please. So there are two types of micronutrient malnutrition. There's type 1 and type 2. Type 1, growth will continue in the early stages, and deficiencies of these micronutrients will result in specific clinical signs, right? So it says there anemia, which happens when we have iron deficiency, or beriberi when we have particularly thiamine deficiency, or scurvy with vitamin C. And then we also saw the xerophthalmia as pictured in the slide before this, and that's to illustrate vitamin A deficiency. All right, so for type 2 micronutrient deficiency, so these would be like your sodium, potassium, electrolytes, amino acids. So having this deficiency results in growth failure, because these are exactly components that we need for our body's metabolism for growth. There are no specific clinical signs, and yet you will present with patients, or you will get patients who will have growth failure. Okay, next slide. All right, so other types of undernutrition. So fourth is fetal growth restriction. So this is abnormal fetal growth. You may have babies who have low birth weight, or those who are born with weights less than 2,500 grams or 2.5 kilos. And this is rooted in poor maternal nutrition. So you see here, this ties up pretty well with the first 1,000 days, right? Because in the first 1,000 days, we already count the time of gestation or pregnancy. And so you have poor maternal nutrition as a risk factor. It then compounds the development of this fetus and resulting in fetal growth restriction as one of the factors. And for babies who are fetally restricted, when they're born, they're 15 times higher risk of death compared to babies born with normal weight. So if you see that photo on the right-hand side, this illustrates a baby with fetal growth restriction compared to one who is born at normal weight at term. And then number 5, in as far as our types of undernutrition. So again, we've gone through acute malnutrition, chronic malnutrition, micronutrient malnutrition, fetal growth restriction, and number 5, suboptimal breastfeeding. I think we have to go through first what is optimal breastfeeding for us to know what is suboptimal. So optimal breastfeeding, the components would be early initiation of breastfeeding after delivery. So within that first 60 minutes, or that golden hour, as ensconced within our essential newborn care program, right? And then we have exclusive breastfeeding for the first 6 months of life, and then continuing breastfeeding. And that's already with the timely initiation of complementary feeding after the age of 6 months, and continuing on up to the age of 2 or even beyond. Right, so breastfeeding not up to this standard potentially causes 800,000 child deaths every year. So let's all take that in for a moment. And this is something that's huge, because breastfeeding is usually presented as an alternative in feeding, when in fact, breastfeeding in itself is an intervention. It's a health intervention for children to survive. So anyway, next slide, please. All right, so we've gone through the different types of undernutrition. And I think this slide has been given away because this is supposed to have some animation, but this is just to highlight the differences between what is wasting and stunting and compared to a normal child. So you have 3 kids here of who are of the same age. The child on your left and at the middle are of the same height, whereas the child on the middle and on your right-hand side have the same weight. So this is really just to illustrate the differences between what is the normal. So if you look at weight for age, height for age, and weight for height, it will be all normal indices for the child on the left-hand side. And then for the child on the right-hand side, the weight and height for age are both low, but the weight for height would be normal. So if you take just the weight for height, then you would be mistaken to believe that everything, all systems clear, but this is a child who is stunted because the height for age is low. And therefore also the corresponding weight for age is low. And then you have the child in the middle who has low weight for age, but the height is appropriate. And therefore the weight for height is low. And so you have a patient who appears wasted or thin. They would say that thinness is basically having low weight for height. And lightness is when you have a low weight for age. So hopefully that's not too confusing, and these concepts will be further made clearer later in the next session. Next slide, please. So why are we focusing on undernutrition? Basically, it says so there, it kills. If you look at the listing on the left-hand side, these are the causes of undernutrition as we have elaborated. And look closely when it comes to fetal growth restriction at the top of the table and suboptimal breastfeeding. They are contributing as well to a lot of deaths for the less than 5-year-old age range. And then you have stunting as well, 17%, and being underweight, 17%. So a lot of deaths happening because of undernutrition. So click the slide, please. So it causes 45% of childhood deaths. So again, just getting it into our consciousness. We see a child who is not being breastfed or is being mixed fed. That in itself is a red flag already that could potentially lead to further morbidity or an increased risk of ill health. And the issues with suboptimal breastfeeding, this would be highlighted further by Dr. Mian Silvestre in her talk tomorrow on acute malnutrition in infants. So next slide, please. All right, so for those who survived, those who escaped, that 45%, there is a lifetime of ill health that could be before them. There's unrealized human potential, because as we saw, those with chronic malnutrition, beyond 2 years, the growth deficiencies may be irreparable beyond 2 years, right? And malnutrition can actually span generations, and we'll see that in the next slide. Next slide. All right, so here we can see how malnutrition can span generations. So if we look at the biggest oblong shape there with malnourished women and those who are pregnant. So imagine you have a woman who is malnourished, and in that context of poverty or having poor access to healthcare and also poor access to care herself. So this woman is therefore at risk of giving birth to a baby who has low birth weight. We talked about fetal growth restriction and having a risk factor of a mother who may have had poor maternal nutrition. And therefore, this baby who was born low birth weight, and what did we learn earlier? They are actually at higher risk for morbidity and death. So if this baby survives and there's no intervention and there's poor caregiving practices, and then there would be inadequate growth, this child will most likely become stunted. And then the stunting, as we said, it could be irreversible beyond the age of 2. And then this child will grow, become an adolescent herself. And then in that context, continuing, likely will then get pregnant herself and then present with the same situation as did her mother. And so this malnutrition could really become intergenerational unless there is an intervention at any point in time during these stages. So this is where us in the healthcare system, or not even the healthcare system, but in society, as a community, that we can help to intervene and break this cycle. Next slide, please. So earlier, I gave you a bird's eye view of how prevalence of undernutrition or childhood wasting here in the Philippines is. It's at 5.7%, as we'd already mentioned earlier, as of the 2019 National Nutrition Survey update. But really looking back over 30 years, it hasn't really changed much. Like if you look at 1989, we were at 6%. Right? And now 2019, 30 years later, here we are at 5.7%. But, this is not to totally put down efforts from our government or from ourselves, because if we look at 2013, we were at 8%, and now 2019 we're down 5.7%. So yay, we're doing something right. However, now the pandemic is hit, hunger again has risen. So we'll have to see what the effects of that pandemic has been to our trend in as far as childhood wasting is concerned. Can I have the next slide, please? So here we will see then the breakdown in as far as who are affected when it comes to wasting. The different colored bars here represent different age groups. So you have that first blue color, 0 to 5 months, and then 6 to 11 months is the orange. And then in peach, you have 12 to 23 months, and then 24 to 35 months for the next blue, and purple is 48 to 60 months. So the dotted line that drives across is the prevalence of malnutrition, of undernutrition or wasting, which is at 5.7%. As you can see, that line drives across the bars that represent those who are less than 24 months. So we need to up our game, and given that everyone here, most of you here, care for children, particularly with cleft, this is also the critical period for your catchment of patients. So we need to act more to help these children. Next slide, please. And so this is how our undernourished Filipino children look like. They're not necessarily just what we call in Filipino butot balat. The child in the middle also has SAM, right? Severe acute malnutrition. But you have a bloated belly, and then the child on the right-hand side has moderate acute malnutrition. To your eye, just may look like any regular kid, but doing the correct measurements, anthropometry, and therefore screening and picking up on the malnutrition, this gives us an edge. These are our tools to give us an edge in the fight against malnutrition. Next slide, please. Let's talk about stunting. In 30 years, we've decreased in as far as prevalence of stunting, almost 15%. And this has been quite a low descent. And our country remains one in the top 10 for having the highest levels of stunting globally. As of the 2019 National Nutrition Survey update, we were at 29.6%. When globally, really, the prevalence, I think, is closer to 15%. So we really should be doing more when it comes to looking after our children, especially in that critical period of the first 2 years, as we'd already emphasized. Next slide, please. So, when we talk about Filipinos, we say, oh, we're naturally short, or as we say it in our language, mga pandak talaga tayo. But really, our kids can be more than that, not naturally short or pandak. It just may be that we need to contribute more to support the nutrition of our children, to screen them more, to find out who are affected, and therefore to help optimize their growth and development. Next slide. So what is it that we can be doing more? I'm sure everyone's familiar with the Sustainable Development Goals. Our country is party to this. And SDG 2 aims to end hunger, achieve food security, and improve nutrition and promote sustainable agriculture. So we are party to this. And by being party to this, our country has elaborated policies that should have translated already into programs that will help combat hunger and fight malnutrition. Next slide, please. So with that too, there are global nutrition targets, which our country as well have signed up for. And I think just to focus on the targets in as far as undernutrition is concerned, we have signed up for a 40% reduction in the number of children under 5 years who are stunted. So I think for our country, given that over a 30-year span, we've decreased our numbers by 15%, we really have a lot of work ahead of us if we want to achieve even 40%. No? Given these malnutrition targets by 2025, we need to commit. We may not make it by 2025, but we need to commit that we will do it in our own defined timeline. And then there's also the reduction of childhood wasting to less than 5%. We're at 5.7%, but as you saw in our trend earlier, we're really at a standstill, basically, or status quo, or at a plateau when it comes to wasting. So we need to give that extra push ourselves. Okay, this is our challenge. Next slide, please. Okay, so to reach the goal, we have mapped out, and this is coming from, as I said, with the SDGs, our participation, our government has ramped up in as far as the policies and protocols that would be in place in order to address causes of undernutrition, which we have discussed or gone over earlier. And so there are corresponding nutrition sensitive and specific interventions that have been put in place. Okay, so as health workers, we are focused on nutrition specific interventions that would impact the individual directly. Next slide, please. And I keep on mentioning the government. So in as far as government is concerned, DOH, our Department of Health, has actually mapped out a strategic framework in order to institutionalize all these plans and programs, and therefore have them get translated down, disseminated to the level of the community. As you can see here, SAM and MAM management is part and parcel of this framework. But this is also not to take the spotlight out or away from preventive interventions, which is where we should also be putting our time and effort in. As mentioned by Dr. Mian earlier, even with Cleft or in general, it's always good to be preemptive. So let's go to when we can still rectify the most, which is during the preventive stages. Next slide, please. So mentioned the first 1,000 days already, and this will be further discussed with you tomorrow in the lecture on acute malnutrition in infants. But just to mention, next slide, please, that there is already a law. It's Republic Act 11148 pertaining to the health and nutrition of the mother and child, or Kalusugan at Nutrisyon na Magnanay Act. And this has basically laid down to law the first 1,000 days. And the Department of Health, together with the National Nutrition Council, with support from UNICEF, has already come out with a manual of procedures for the first 1,000 days, and as far as how local government units should be able to operationalize this program. And it could be accessed through that link that you have there on the slide. Next slide. So again, I know this is a recurring thing, but this is just really to drive further, the message that we need to act, whether it be moderate or severe acute malnutrition. You have a child there pictured in front of you. So Fahad is actually a 14-month-old boy who was screened coming from the ARMM, or the Autonomous Region of Muslim Mindanao, or now BARM. and he was screened to have SAM, and he was only 6.5 kilos at the time of screening at 14 months of age. But because of that screening, there was appropriate intervention, and there he is after 2 months of having been treated for malnutrition. And so this is doable. We can intervene. We can treat malnutrition. Next slide, please. So then in comes the Philippine Integrated Management of Acute Malnutrition. You saw in the DOH framework, one of their priorities is the treatment of MAM and SAM. So here, this has actually been put together, and this is coming off from recommendations or existing protocols globally already. It enables the community management of malnutrition. You see there in front of your screens that previously malnutrition was something that we treated in the hospitals, but hospitals aren't really a good environment for treating malnutrition. And for those reasons elaborated in front of you. So we needed to have something better. Next slide, please. Next slide. And therefore, we need to treat children with severe acute malnutrition and moderate acute malnutrition with up-to-date treatment protocols, because we have to appreciate that SAM kids, they don't have the same physiology as a normal child. They cannot be medically treated like any other sick children. And this will be elaborated on further by Dr. Mian tomorrow in the lecture on referral, triage and referral. So malnutrition actually alters the SAM child's physiology. There is the thing that we call reductive adaptation. And again, more of that tomorrow. And old treatment protocols that surround, hospital management can do more harm than good. And so SAM children require specialized treatment. Next slide, please. So we need to treat them specifically, specially, to address their malnutrition. And, usually we'd be more sensitive to these types of acute malnutrition during emergencies. And even more so for MAM. So we need to have that heightened index even in the non-emergent situations. And particularly for this crowd here, you would be, because you are tending to a particular subgroup of patients. And these are patients with cleft lip and palate. And so we already know that they are integrally predisposed to developing these issues. Next slide. All right, so with PMAM, so the management of MAM and SAM should be part of routine health and nutrition services at all levels, okay? So it isn't something that we just screen for during an emergency, but it should be integrated, like in a well child visit. We usually take measurements, but we don't take the next step further, which is to actually interpret, what are these measurements meaning? So also the screening for malnutrition relies on a strong community component. So this is also the beauty of PMAM. So it is not merely the health system side, but it also relies on the participation of community. Next. So there are 4 guiding principles with PMAM. There's maximum coverage and access, which is to bring the treatment into the community, into the local health facilities, the RHUs. Timeliness, meaning because community is participating in this, there's more sensitization and there's earlier case finding, and therefore there's earlier consultation for management. And then appropriate care, wherein treatment can be given even in the home, where the families would be more comfortable. So, and this is based now on the various indicators which will dictate where care should be given, which is the 4th guiding principle in as far as where the care could be delivered. Next slide, please. So the innovation in integrated management, I think I've mentioned it already. It's really involving the community, when before in the old algorithm, it was just really about treating it in hospital, but now, and you will learn this a lot more tomorrow, there is a distinction between malnutrition that can be treated in the hospital versus malnutrition that can be treated in the community at the comfort of home. And then there's also the recognition of moderate acute malnutrition. And what can we do to intervene in order to support the nutrition of these children as well? Next slide, please. So components of PMAM. So we can manage severe acute malnutrition as far as without complications in an outpatient setting, so in the OTC, as we call it. And then there's the management of SAM with medical complications in the ITC, or in the inpatient therapeutic care, as we say it. And then there's the management of MAM, or moderate acute malnutrition, via targeted supplementary feeding programs. And also a critical part of PMAM, or a component, is community outreach, as I've already emphasized. And this is community mobilization. And we'll be discussing this more tomorrow as well, as part of the talk on referral and triage. Next slide, please. So I think I went ahead of myself. I've already said earlier, we were party to the SDGs, and the government has done its share already in developing these policies and programs. So just so that we are cognizant, in 2015, the Department of Health came out with the national guidelines on the management of acute malnutrition for children under 5 years. And so it elaborated on the protocols. And this is what Dr. Buku, Dr. Drew had earlier mentioned, is that effort, that collaborative effort with government and non-government to come out with the guidelines in as far as the implementation of protocols in the management of acute malnutrition, be it severe or moderate acute malnutrition. So in these guidelines, there's emphasis on the critical aspect of having linkages, of having networks, be it in emergency settings and not. And the roles are well defined, particularly at the level of the community. Next slide, please. Okay, so in summary, I think we've gone over quite a bit, but just to reiterate, identification of MAM and SAM is an important skill. Why is it important? Because we know how much death could be foreboding or coming for these children who are affected. And so this is an important skill for those who work in health, even from the level of the community at the barangay up to the hospital level. Acute malnutrition is wasting. And then moderate acute malnutrition is moderate wasting. And severe acute malnutrition is severe wasting. And the classification of malnutrition to moderate or severe is dependent on anthropometry and testing for edema. And you will have that in the lecture coming ahead now. And then it is important to actually do the accurate measurements. I think the very bottom line is we need to be heightened in as far as our awareness. So we need to really screen well. I know most of you here who are coming from the Philippines would know, one of the pitfalls of our Operation Timbang way before was that we would just be recording weight and height, but the corresponding analysis or interpretation of what weight and height meant was quite lacking. And therefore, there was a delay in screening, and therefore that also means a delay in management. So let's not do that. When we correctly identify, know that we will be able to save a child's life. So I think that ends my talk. I think I went over a little bit by 10 minutes. I apologize for that. And there will be room for questions at the end of this afternoon. But I think for now, we will take a 5-minute hygiene and wellness break. Is that correct, Dr. Drew?
Yes,
thank you.
Thank you very much, Dr. Donna, for that quick but very comprehensive lecture. it was a good glimpse in terms of an overview on acute malnutrition from a quick background, including challenges and also the potential solution for the problem. So up next on our program, though, we are scheduled for now to take a quick wellness break. So we will be having a quick 5-minute break. Please take this opportunity to stand up a bit, stretch, move around, maybe get something to drink as well. And in the interim, we'd like to remind everybody once again, we'd like to invite you, if you have any questions, to please use the Q&A tab on the bottom of your screen in Zoom. Please use that tab to put your question, to place any questions that you may have. Unfortunately, as of this moment, we cannot acknowledge any hands raised and ask you to speak as of right now. So we just like, if you have any questions, please use the Q&A tab at the bottom. So after our 5-minute break, we'll be reconvening for our third and last lecture for today, after which we'll be having an open forum. So right now here in the Philippines, it is 3:26. So roughly we'll reconvene after in around 5 minutes. So around 3:31, it's now 3:27. So around 3:32 Philippines time. Kindly adjust according to your time zones. Our apologies for that. But we'll see you in 5 minutes. Thank you very much.
From the time they are born, children with cleft lip and/or palate face many challenges. They struggle to eat, breathe, speak, and even survive. Treating cleft lip and palate requires a range of long-term, comprehensive cleft care interventions. But around the world, there is a severe shortage of medical professionals with the skills or resources necessary to provide this specialized care. This is why SmileTrain, as part of our sustainable partnership model, offers a variety of innovative training and educational resources to cleft care providers around the world. For over 21 years, we have partnered with cleft care professionals at more than 1,100 hospitals in over 90 countries, offering more than 40,000 training opportunities, a number that is growing every day. Over the coming years, SmileTrain will scale these programs and resources because we know that behind every smile, there's a team of healthcare professionals who made it happen.
Maraming challenges rin na pagdaanan ko. Nandiyan yung tinutokso ka, nung bata ka. Siyempre, ikaw, nasasaktan ka, di ba?
Hindi ko lang sinasabi kay mama, pero may times na binubuli pa rin ako. Halos araw-araw yun, pagpapasok ko sa school. Tapos, nasa rin ka nila ng bingot, gano'n. Tapos, halimaw.
Mga classmates mo, ina-assert mo ako. Inat-assert mo minsan, ina-assert mo ako. Mananalahat mo ako, tinatawanan mo ako.
Nung baby na po ako nilang parang i-opera po ako. Alak po nila parang, mamamatay na nun po.
In the Philippines, there are about 5,000 babies born with a cleft lip and/or palate annually. Cleft is far more than a cosmetic problem. Children with untreated clefts not only live in isolation, but also face physical difficulties with eating, breathing, and speaking. As a result, most of them don't attend school or ever hold a job. Cleft repair surgery is safe and the transformation is immediate. SmileTrain is the world's leading cleft charity that supports comprehensive cleft care, including surgery, orthodontics, dental services, speech therapy, nutrition, and psychosocial support. SmileTrain's sustainable model focuses on training local medical professionals in more than 90 countries to perform cleft repair surgery and comprehensive cleft care in their own communities. They then go on to train others, creating a long-term, sustainable system.
Kung hindi ako na-operahan, siguro baka wala ako dito ngayon. Baka nasa bahay lang ako, nagtatago.
Magiging normal na rin yung buhay ko, yung wala nang manlalait sa akin.
Masaya po, maayos-ayos ako, makakapunit ko kanila po natin.
Ngayon po, nakakangiti na po ako. Natutunan po ng smile train.
Cleft repair surgery may take as short as 45 minutes, but the impact is life-changing. Former patients have the opportunity to attend school, get a job, start a family, and contribute to the society at large. Refer someone in need today and give the gift of a smile and a second chance at life.
So good morning, good afternoon, and good evening once again, everybody. So we'll just take a few more seconds to wait for everybody to come back. And as we reconvene for our session. So just a few reminders for anybody who may not have answered the pre-test as of now. The link is in the chat. Thread. So kindly please answer that question. I think it's a requirement for you to be able to receive your certificates also. So please make sure that you don't miss out on answering the pre-test. So just to check on our end, if we're good to go, if we can see the first slide of the next presentation on the screen, just to have it ready. Once again, we remind everybody, if you have any questions, kindly use the Q&A tab on the bottom of the Zoom panel. We unfortunately are not able to answer to put the spotlight on anybody who in the room to speak up for their questions. So kindly use the tab for now, but you might have that opportunity later on. Okay, so the slides is appearing now on the screen. So kindly please move to the next lecture, our third and last lecture for this afternoon. So in the interim, we actually have a question for you guys as of now, but just food for thought while we're waiting. Based on the lecture earlier on, we can see here there's just a checkup question. Which of the following is a case of undernutrition? So is it A, a child who never reaches full height due to poverty, poor sanitation, lack of breastfeeding, and limited access to nutritious foods? Letter B, is it a young woman who becomes anemic during her pregnancy and gives birth to a baby with low birth weight? C, if it's a child made blind by vitamin A deficiency. Letter D, a desperately thin and wasted child at imminent risk of death. Letter E, a 9-month-old baby who has no edema and with a MUAC or a mid-upper arm circumference of 12.1 centimeters. So it's okay, I think, if we can just move on to the next slides. So here, actually, I hope everybody was able to get this quick answer. Actually, all of these situations are actually an indication of malnutrition. So it's okay. It's don't worry. It's at this point in time, a lot of us come from different backgrounds, and it's normal for many people to identify actually just one or two of these as types of malnutrition, but in reality, all of these are actually types of malnutrition. It's important for us to be able to recognize all of these types in order for us to be able to properly identify and then move on into the treatment of the type of acute malnutrition. Okay, so let's just move a bit more. Okay, there we go. So just to jump off from Dr. Donna's lecture. So as she mentioned earlier on, she gave a quick overview of the problem of malnutrition. There's no doubt about it that there's malnutrition still, despite it being already being 2022, it is still unfortunately a problem. And what's frustrating about it, actually, it's a problem, but the solution is actually already there. It's a very simple solution. We have all these programs at the ready for us to be able to address malnutrition. So and we can see that the actual interventions are not so difficult, and they're actually already there in our health systems. It's a matter of us being able to properly utilize and wield what we have right now in order to provide the proper health and nutrition services for our children. And of course, as Dr. Donna was mentioning earlier, before you actually treat these children who have malnutrition, it's very important for us to be able to screen and identify these children. It doesn't matter if you have all of these fantastic programs at your disposal. If you are not able to identify who are actually acutely malnourished, then all of these go to waste. So it's important for us to be able to identify who among our children are acutely malnourished. So let's go to our next slide. A quick disclaimer for this. So this whole webinar is actually extracted from the training modules that we've been conducting in the Philippines. So it's actually part of a training of trainers, and actually I see a lot of our participants who we miss very dearly, who were actually part of our trainings, who are part of our previous trainings. So but this particular lecture, this lecture in particular, is at a bit of a disadvantage, because the training was originally designed with a face-to-face interaction in mind. So this particular module actually was initially designed with a return demo type of lecture. But unfortunately, of course, because of the pandemic and because of this situation, where we have to do it online. But still, don't fret. We will still push through with the lecture, of course. We've tried to tweak it a bit in order for us to still be able to appreciate the different parameters that we are using to identify children with malnutrition. Hopefully later on, of course, the pandemic is still going on, but at least we hope that this will give you a taste of what it takes to identify children with malnutrition. So for this particular module, at the end of the module, we hope that you will be able to identify children with MAM and SAM. Secondly, to determine a child's age appropriately, to measure weight and the height or the length correctly. Next, to determine the appropriate Z-score based on the weight and height. To measure the mid-upper arm circumference correctly, to test for the presence or absence of edema, and to perform the appetite test. So as of now, these concepts may seem abstract, but I guarantee you that by the end of this lecture, you will have a greater appreciation of these particular parameters and how these come together in order for us to be able to identify who are in need of treatment and who have acute malnutrition and who are in need of treatment. So next slide, please. So in terms of measuring malnutrition, we actually have different parameters that we can use. It was already touched on briefly in the previous lecture, but for example, we can actually use clinical signs in terms of checking if a child is malnourished or not. So especially if you're coming from a health background, you can actually inspect or do a physical examination of the patient, and and there are certain signs or symptoms that are identified with having malnutrition. So for example, if you can see firsthand that the child is very thin or emaciated, or if or other signs such as some more specific signs that come with training, like noting that there's a discoloration in the skin, or there's a change in the hair color, or there's or there's signs of signs that may look like dehydration, like having sunken eyeballs, or as Dr. Donna was mentioning previously, that there's signs of bilateral edema. These are clinical signs and symptoms that when a health worker will be able to see them, it's basically, you can say that this child is malnourished. However, what is important to note here is that in some settings, it's not all health workers may have had that training. And so even if these clinical signs and symptoms are present, some people may not be able to to identify these properly. And at the same time, some of these these are highly dependent on having a good clinical eye. So and sometimes these parameters are subjective. So if your training is not as if a person is not as exposed and not seeing patients as frequently, then you might have difficulties in identifying children with malnutrition through clinical signs. So another parameter that you can actually use is biochemical testing, which basically refers to tests like for the blood or for the urine, where you look at the biochemical composition of an individual in terms of whether he has the proper nutrients or the proper electrolytes within his system. The problem here is that these are very test dependent, and especially if you live in far-flung communities or in rural or in urban poor areas, basically some of the tests may not be available. So it kind of defeats the purpose, because you want to be able to quickly identify these children for treatment. But if you're going to depend on biochemical testing, there's a lot of delay in terms of if you don't have the equipment ready, and of course also in terms of cost, because these tests definitely do have costs which an area may not have, which the area may not be ready to shoulder at that moment. Thirdly, you can also look at dietary intake in terms of whether a child is eating properly. It's also in terms of it may be as simple as just looking at the child, whether the child is eating or not, whether the child has appetite or not. But you also look in terms of the quantity of the food that he's eating, and also the quality as well. But again, this is actually subjective, and sometimes it's dependent on the guardian who needs to narrate what the child has been eating over the past couple of days. And it's very easy from experience, it's very easy for guardians not to be able to report it properly. So these are actually, sometimes these parameters are not that reliable. So this actually leads us to our fourth measure on the screen, which is anthropometry, which is a study or technique of measuring the physical body measurements as a proxy of sorts to determine whether a child is growing, or maybe on the other hand, whether there is lack of growth. So it's important for us to be able to use anthropometric measurements like such. We will be going on into this in the next particular slides, to use these particular measurements to identify whether a child is malnourished or not. So next slide, please. In terms of the measurements that we're going to use, the first one, which is kind of counterintuitive, because it seems that it's very easy already, and not so very important because we tend to take it for granted, is to measure the age. So next slide, please. It's very important for us first, before taking any weight or height or any other measurements, to determine the age and sex of the child. So it's important to know, because firstly, we know that girls and boys grow and develop differently. It's not fair to compare a boy who is 2 years old with a girl who is 2 years old. There's definitely a genetic predisposition that boys and girls do not grow at the same rate, especially at this point in time. So it's important for us to be able to determine the age and sex of a child before you proceed with the measurements. And for us, it's very easy to take this for granted, because when we report age, by default, we automatically say that the child is 1 year old, 2 years old, 3 years old. But in the world of nutrition, we actually need to report the age of the child in months. So this will become clearer later on when we put all these parameters together, because the tools that we will be using needs to take into account taking the age of the child in months. So it's actually also, just for a quick background, maybe in our particular setting, it's very easy. Like, you just ask a mother or the guardian that what age is the child. The person will easily recall the birthday. But in some settings, it might not be so straightforward. Sometimes they are dependent on seasonal seasonal indicators, like maybe they will say that, oh, this child was born 3 full moons ago, or the child was born during the last harvest season. So sometimes in these particular situations, you have to be a bit more creative in trying to correlate when is the right date for this. But bottom line is determining the age has a significant implication on whether you can say that the child is malnourished or not. So let's just do a quick exercise. Next slide, please. So actually, this whole lecture might seem a bit rote in terms of something that most people take for granted, because it's something that seems to come second nature to everybody, but actually in reality, it's something that our training participants from the previous trainings really appreciate, because it's a way of going back to the fundamentals in order to check if we have a good understanding of the fundamentals in terms of anthropometry. So in determining the age in months, let's use this particular example. There are two important dates in determining the age in months. Firstly is the child's birthday, and secondly, the date when you will be seeing the child. So in this particular example right now, we will be using two particular dates. The first date above, March 14, 2021, we'll use this as an example. This is the date when the child, let's assume that this is the date when the child was examined. And then the date on the bottom, November 8, 2017, that is the date when the child, that is the date of the child's birthday. I see some people commenting already in the screen. That's great. We'll check if your answers are correct. So what we need to do in this particular setting is that we need to convert these dates first into, we'll be doing a bit of math basically. So we need to convert these dates into numbers. So please click for the animation. Okay, so we convert these dates. So the first date, March 14, 2021, becomes 2021-03, because March is the third month of the year, and 14 because we're talking about the 14th day of the month. And then for the birth date of November 8, it becomes 2017-11, because November is the 11th month of the year, and 08 because we're talking about the eighth day of the month. So it's actually very straightforward. Health workers in the Philippines are quite afraid of math, but actually you shouldn't be afraid of math, because math is your friend. Actually, it's very important, and it's also a very important tool for us to be able to properly identify the anthropometry of these children. So in this particular case, we just do a bit of math. It seems to be a bit straightforward. So we go from right to left. So like it's 14 minus 8, it becomes 6. But when it comes to the second column, for the column on the months, it becomes a bit trickier, because offhand, you can't do a 3 minus 11, basically by subtraction. And it doesn't follow the usual mathematical parameters, because what you do here is that you take 1 year away from 2021, but before you add it to 03, you have to convert the 1 year into months. So 1 year becomes 12 months, basically. So you add 12 months to 03, and that is why, as you can see on top, it becomes 15. So, and then 2021 now becomes 2020, because we took 1 year away from that. And now it becomes a quick, straightforward case of subtraction, where you take 50, you subtract 11 from 15, and you get 4 days, 4 months, sorry, 4 months. And then for the leftmost column, from 2020 minus 2017, then you get 3 years. So basically, the difference between these two dates is 3 years, 4 months, and 6 days. However, in terms of nutrition, you have to convert it into months, right? So what you do, please click for the next slide, for the next animation. Okay, so we've done this already. One more time. So you, whoops. Okay, it's all right. So what you do is, for the 3 years, you have to convert it into months. So because there are 12 months in 1 year, you multiply it by 12. So it's 03 times 12, and you get 36 months. So in reality, what you have there is 36 months plus 4 months from the second column, And then if you add that together, I see a lot of people actually in the chat have already been giving their answers. You get, please click for this answer, 40 months for this particular child. So just to recap very quickly, this child who has a birthday on November 8, 2017, was seen at the health facility for a nutrition examination on March 14, 2021. So when you put all of this together and you determine if you want to determine the child's age at that particular point in time, on March 14, 2021, that child was 40 months old. Okay, so I know that this can be a bit daunting for some people, and normally in our trainings we have several exercises where we do this, and we sit down with the trainees to do this for different examples. But unfortunately, in the interest of time and in the Zoom setting, we cannot do that. But we will have one more example. So I invite everybody to try to follow. We will be going through another example, and at the end, hopefully before we reveal the answer to this one, there will be a poll question. Kindly indicate your answer as to the age and months of this next example. So Alex, let's go to the next slide. So for our next exercise, let's do this example. So we have another child where the date of examination is April 18, 2021, and the date of birth is October 22, 2018. So let's walk through this particular example. Next slide, please. So firstly, what do we do? Since this is still written in words and numbers, we have to convert it purely into numbers. So please click for the next animation. Okay, so April 18, 2021 is converted into 2021, 04, April being the 4th month of the year, and 18 on the last column because this is the number of days. And then click once more, please. For October 22, 2018, which is the birth date of the child, it's converted into 2018, 10 because October is the 10th month of the year, and 22 because we're looking at the 22nd day of the month. So of course we next basically do the math, but in this particular situation it's a bit more tricky because it's not straightforward math. So kindly click for the next animation. I'm seeing some answers on the screen, so let's try to we'll see if the answers will be correct. So what we do here though is, because it's not too straightforward, please click one more time. So we for the rightmost column in terms of the days, we can't just do a simple 18 minus 22, right? So we have to take some days from the month. So we take 1 month from 04, and but in order to convert it into days, we have to multiply it by 30. Take note, it doesn't matter if we don't look whether it's if the month has 28 days or if the month has 31 days. We standardize it as having 30 months basically, 30 days basically. So we get 1 month from the month column. We convert it into days, so it becomes 1 times 30, and 30 is added to 18. So you get the total number of days in that particular column. And then, but for the months, you also have to take 1 year from 2021. So again, you convert that into months first before you add it to the months column. So kindly click for the animation. So as you can see, the values on the screen. So the days become 48 because you took 30 days from the months column and you added it to 18 for 48. And then for the months, take note it is not 16 because it's from 04 it became 03, and then you added 12 months to it, so that's why it became 15. And then for the year column, it's basically 2020 minus 2018. It's a bit more straightforward, so you get it's easier to calculate. So kindly click one more time. Okay, so that's what we have right now. So we have 2 years, 5 months, and 26 days. So putting that all together, what do we get? Let's try to see. Let's try to see if this poll, if our poll will work. So what we're asking for is please indicate your answer in terms of the age and months of this particular child. So kindly refer to the screen please plug in your, we'll give you a few seconds to please plug in your answer. And we'll try to see if how many people got it right. And we're very happy to see 246 participants. Well, actually 264 participants. And we invite everybody to take part in the poll. I see in the chat that people are indicating the number of days. That's very precise. Thank you very much for that. In this particular situation, though, we just need the age in months. So answering in months will be enough. So, okay, so I think time is up. And let's share our results. And this is what people have written down. The age in months is 29. So Alex, can we see if they got the answer correct? Can we click? 29. So as you can see on the poll, 93%, I'm not sure if you can still see it on the screen, but 93% of the participants were able to get it right. So thank you for that. Okay, so let's move on now. So we normally do more exercises to take the age in months, so, but unfortunately in the interest of time, we have to move on. So it's actually also, we actually also received the question, this next question a lot. Is basically they're saying that we have all of these calculators now, and we have all these apps that can calculate the age in months of a child. Why do we need to learn these fundamentals? It's actually more of a reflection on our particular setting in the Philippines, that not everybody has access to applications or even calculators actually. So it's very important for the community health workers to be able to understand and appreciate the basic math involved in this, because as you can see, making a mathematical error might have big implications later on in terms of determining the proper nutritional status of a child. So even something as simple as taking the age of a child is very important. And if you have the apps available and you're completely sure that they work, then that's great. There's no problem with that. But it's always important for us to remember the fundamentals and how to compute the age and months of a child using the formula that was described earlier. So let's move on a bit in terms of measuring malnutrition. We go back to our discussion on anthropometry, which again is a study and technique of taking measurements of the human body. And it's a method to assess the growth based on measures of physical characteristics of the body. And as we mentioned earlier on, we're going to go through these different measurements on the screen in terms of age. Well, we've gone through age and sex already, and these are more straightforward, but we're also going to go through weight, height or length, and the mid-upper arm circumference, as well as other measures later on. So next slide, please. So firstly, we'll go to measuring weight. Next slide, please. So again, all of these things may seem a bit straightforward, and this is basically just a review, but as we can see on the screen, there are some people who are appreciating this actually, because it's very important for us to be grounded in our fundamentals before we move on to the actual treatment of children with malnutrition. So measuring weight seems very straightforward, right? But it's very important for us to be able to have a standardized way of measuring, of taking anthropometric measurements, whether it's weight or height. So for this particular section, we'll be concentrating on weight. In the Philippine context, what is being used in health facilities is a Salter scale. As you can see on the screen, it's a Salter scale, and it's the contraption on the screen is that the child is placed in a secure cradle of sorts in order to make sure that the child will be comfortable and will not fall off, and that the child will be properly balanced so that we can get the proper weight. What some people take for granted, these are actually things that we take for granted, but it's very important that when you measure weight, you take the measurement at eye level. It's important for the scale to be, you measure it as close to your eye as possible, because if you take it from a far off distance, there's the room for error grows even more. So somebody who is reading it from different distances may not be reading it as accurately, especially since in terms of weight, you measure to the nearest 100 grams. And the Salter scale is very much equipped to be able to determine that weight to that precise measurement. So as you can see in the pictures, a hanging scale or a plastic basin or a malong is how do you say it? It's a culture. It's a garment here in the Philippines that it can be used to carry the child what is important here is that the child can be placed comfortably in the seat so that you can properly measure the weight. The carrier should be as close to the ground as possible to avoid any possibility of the child falling down. The pictures on the screen are actually quite ideal. I'm sure that people in the community know that it is not quite as straightforward as this, especially when you get children who don't want to be measured for their weight. And you get children, the children here are all very well behaved, but we know that that's not always the case. And it's also part of the excitement of our daily community routine, where we get children who we may need to be more, we need to be more patient in terms of getting their anthropometric measurements. One more thing to note is that it's best if the child does not have any clothes or anything on the child that may influence the weight when you take the measurement. So if, for example, especially if the child is wearing clothes like for denim or actually any kind of clothes or any kind of jewelry, sometimes these do have an effect on the weight. So as much as possible, try to take the weight of the child with no clothes on. However, we do understand that there are cultural sensitivities involved. So it depends. It's also we have to do this on a case-to-case basis as well. That we adapt to the cultural norms in the community that the child belongs to. So in these particular cases, sometimes what you can do is that first you weigh the child with all the garments on, and then discreetly, if you can do it later, and then you take the garments and you measure them separately, and then you subtract and you do a bit of a math to do some subtraction to take the actual weight of the child. It's a bit more complicated, but then again, we have to adapt to the particular setting. It's as we can see in the chat. It was duly noted that as much as possible, if the child has light clothing, that's okay, because as long as you can ensure that the clothing will not interfere too much in terms of influencing the actual weight of the child, that will be okay. And it's very important to note that when you take the weight, try to record it immediately. It's very funny especially when in the cases where you have children who may not be as well behaved as in the picture. Once you get their weight, and you're able to get their weight, and after all of the fuss, you forget to write down the measurement, and then you have to do the process all over again. So it's very important for you to record the actual weight immediately, so that you don't forget this so that you don't have to repeat the process later on. So once more, thank you for that comment I see in the chat. It's important to check for the baby's diaper if it's wet or not. So it's definitely, if the diaper is wet, it will very much influence the weight of the child, the weight that you are taking. So you have to address that properly. If you can do so, take the weight of the child without the diaper. Okay, so next slide, please. Just a quick note on this slide. We won't go too much into the details for this, but what we just need to emphasize is that when you do take the weight of a child, you have to make sure that the scales are standardized. You don't get any scale, and then you don't check if it's measuring if it's measuring correctly, because for sometimes you might be having a scale that is not properly adjusted or is not properly calibrated. So you just have to make sure that the weighing scale that you are using is properly calibrated. So as indicated on the screen, there are certain ways that you can do it. For example, here in the Philippines, we have to routinely check if the weighing scale is accurate by taking 3 known weights, and then you do a triangulation of sorts. You have to make sure that the weighing scale is reading these weights correctly, because if they're not reading the fixed weights correctly, then you know that you have to do some calibration, or you have to replace the weighing scale. So just on that note, we just have to make sure that the instruments that you are using are properly calibrated to get the correct weight of the child. Next slide, please. So let's do a bit of an example here. So we have a picture on the screen. We'll just do another poll. We'll ask you to kindly indicate your answer. Please, we're referring to the technique being indicated on the screen. Kindly say if you think this is correct or incorrect. Kindly use kindly indicate your answer on the poll on the screen. So I think, unfortunately, The poll might be covering the picture, but based on what you recall, try to say if it's correct or incorrect. Okay, so thank you very much. It's great to see that a lot of people are using the poll function. So we'll just give a few more seconds for this before we close it. Okay. 5, 4, 3, 2, 1. Okay, so let's end the poll. And so is this correct or incorrect? Alex, can you kindly click the slide for the animation? The answer is incorrect. And so actually, overwhelmingly, there's a lot of people who answered the question correctly. The technique demonstrated is incorrect. So normally at this point in time, we will be asking the participants to indicate why it's incorrect. But unfortunately, we can't call you up to give your answers. But I can actually already see some people placing their answers in the chat. So you got it correctly. Firstly, one of the glaring errors here is that the health worker or the one taking the measurement is reading the scale not at eye level. It's not at eye level, so there's a big room for error in terms of getting reading the measurement correctly. You have to make sure that when you read the scale, bring it to eye level as much as possible, so that you will be able to read the measurement correctly. And another error that can be seen here, of course, in this particular slide, you can see that this is actually just a demo of sorts also, because they're not actually measuring a child. But as you can see here, if this was a real child, the child here, the child, quote unquote, is wearing clothes. So as much as possible, as we noted, we have to try to measure the child with no clothes on. But of course, again, being cultural, we have to make sure to be sensitive to cultural norms in the community. And then one more thing, thank you very much. I'm so happy to see people are participating in the chat. The sling is also the cradle for the child actually is also far from the ground. So if this child was very hyperactive, there's a tendency, there might be a possibility of this child falling down, because if the child was not properly secured. Of course, this is just an example. So, but what's important for us to note is that there are certain ways to be able to, there are certain standards that we have to follow in taking the measurement of a child to make sure that we get the accurate weight of the child when we are doing the measurements. So next slide, please. So next, after weight, now we go to a quick measurement in terms of to our next anthropometric measurement, which is length or height. So next slide. So firstly, we will do a quick run through. This is the tool that is being used in the Philippines. This is the infamous length or height board. It's a very important tool actually for us here in the Philippines, because it's what we use to correctly measure the length or height of the child. So this particular instrument actually is can be taken apart. Sometimes it's used as the health worker puts it on his back and uses it as he goes around the community to take the measurements of various children. But as you can see, it can be quite heavy. It can be quite burdensome to carry around. But it's very important for us to be able to have standardized equipment, because, for example, it was floated before for health workers to use a steel ruler instead because a ruler in principle would be more portable or easier to transport. But from experience, using rulers, the rulers would tend to be would be damaged, and if the instruments are damaged, then you might end up getting incorrect measurements. These length or height boards are more robust, and they're less prone to damage, at least especially if you take care of them properly. So that's why we just want to highlight that it's important to be able to have the proper tools before getting the anthropometric measurements of these children. So this board can be used for length or height depending on what you need to do, and we will be going into this in the next slide. Next slide, please. So when do you take length and when do you take height? So you take the length of a child if the child is less than 87 centimeters or less than 3 feet tall, less than 2 years old, or too weak to stand. So that's less than 87 centimeters, less than 2 years old, or those who are unable or physically incapable of standing up. In contrast, you take the height of a child if the child is 87 centimeters or taller, if the child is 2 years and older and also capable of standing up. So there's just a minor note at the bottom where there are instances, of course, where this is not always the case. For children who are less than 2 years old or less than 87 centimeters who can stand and they want, and it's more ideal to take the height, you have to make the height is measured, but you have to take away 0.7 centimeters to the measurement. In contrast to the other end, where there may be children who are greater than or equal to 2 years, who are greater than or equal to 2 years old or 87 centimeters who are unable to stand, you take the length, but you deduct 0.7 centimeters from the measurement. This is basically to account for some anatomical changes when you measure whether it's height or length in terms of the compression of the spinal cord, etc. It's not it's just at this point in time though, it's just nice to know for us to be able to determine that there are situations where you have to take the length, there are indications where you have to take the height, but if ever that you have to do the opposite instead, there are certain things that you have to do in order to adjust the measurement to get a more accurate picture of what the child's length or height is. So next slide, please. Okay, in terms of measuring length, this measurement actually is it's a group effort. It's a dyad effort actually. You require a partner to help position the child, and again use the length or the length board. You also have to be familiar with the different parts of the length board actually. So there's a fixed headboard and a movable foot plate. You have to make sure that you place the length board on a level floor. You don't put it on an inclined surface, or you put it on a surface as flat as possible in order to take a more accurate measurement. You, as much as possible, remove the child's socks or shoes or anything that may influence the child that may prevent the child from reclining straightly on the length board. Remove any lower garments or diapers, and remove any worn hair ornaments. So as you can see on the screen, there's two people involved. In this particular setting, the man on the screen is the one taking the measurement, and the woman is the assistant. So the man is placed on the movable footboard. He is holding the feet, and the woman is on the side of the headboard. So as you can see, the assistant is in charge of making sure that the child is positioned properly and aligned in terms of the headboard. There's a proper technique to it, such that you have to make sure that the line of sight of the patient is perpendicular to the base of the board. The patient has to be looking straight up. You have to make sure that the patient is not bending his or her head, or not looking to the side. You have to make sure that the patient is looking straight ahead in order to be able to get an accurate measurement. And of course, the picture is an ideal picture also. Sometimes you get patients who are more belligerent or more aggressive, or they don't want to have their measurements taken. So that's why the assistant is there to help make sure that the child is as calm as possible before you take the particular measurements. So next slide, please. So the child must look straight ahead with his or her head parallel to the baseboard. The legs are straight. The feet are firmly planted on the foot plate, and you read length or height to the nearest 0.1 centimeters. Sorry, I forgot to mention this earlier. On the actual height board on the rightmost side, there is the scale is there in order for the measurer to be able to read it properly. The measurer should be on the side where the tape is in order to be able to see it to view the measurement first directly. So next slide, please. So we'll just do a quick polling again in terms of this position. So we'd just ask you to comment on this particular picture. What do you think do you think that this technique is correct or incorrect? So we'll ask you to very quickly indicate what you think about the picture on the technique involved, if it's correct or incorrect. Okay, so in the interest of time, we'll just do this just a few more seconds. Five, four, three, two, one. Okay, so we end the poll, and this is the brick. Sorry, Alex, can we see what is the answer for this particular slide? It is incorrect, and actually, according to for our participants, most of you answered correct. I think the situation here is that as you can see, the child is actually looking straight up, but the error here is not on the position, not specifically on the position of the child, but more on the technique that the assistant is demonstrating. So ideally, the assistant should be holding the child's head with cupping the ears instead of here on the shoulders, because in this particular situation, the child is very well behaved, but sometimes the child will be moving. If the child is very fussy, he will be moving, and you will not get an accurate measurement. So it's very important for the assistant to be able to restrain the child properly, but not too firmly, just to make sure that the child is comfortable enough for the one taking the measurement to be able to read the measurement accurately. Okay, so one more click, please, Alex. Sorry. So the hand position is incorrect. The hands should be pressing against ears and the thumbs. In this particular situation, the placement of the assistant's hand is not ideal. So next, please. Next slide, please. So now how about this particular position? So once again, let's do a quick poll. So please indicate if you think the technique being demonstrated is correct or incorrect. Thank you very much for everybody. I can see a lot of people participating in the poll. Thank you for that. Okay, we'll just allow a few more seconds. Okay, so we'll end the poll right now. So in this particular position, we're asking if the technique demonstrated is correct or incorrect. And Alex, can you please click for the animation to show? Is this position? This position is incorrect. So in the poll, we can see that 76% of respondents were able to identify that this technique is incorrect. So as we can see in this particular slide, Alex, next slide, please. So it's the position of the child is incorrect because the chin is against the chest, and when the child's head is flexed, you will not be able to get the tip of the head against the headboard, so you will not be getting a accurate measurement. Okay, so next slide, please. There. So once more, again, a reminder, the feet should be flat with the heels against the board. So next slide, please. Oh, so another example, but in the interest of time, we won't be doing a poll for this one. But as we clearly just said one slide ago, how is this position? Is this technique correct or incorrect? So the answer should be overwhelmingly yes. As people are indicating in the chat, it is incorrect. Specifically because the feet are flexed and they are not flat on the footboard, on the foot plate. So, okay, next slide, please. Incorrect, okay. So previously we were demonstrating the technique for length. Now we will be demonstrating the technique for height. So once again, it takes two to tango. It requires a partner, but this time you place the height board in a vertical position. As you can see in on the picture, we will be zooming on that later on. You still have to place the height board on a level floor, and you still have to remove any clothing or any accessories that might interfere in you taking the correct measurement of the child. Next slide, please. Sorry. Okay. Sorry. Can you go back one slide, please? Sorry. Yeah. So just to, it's actually pretty much a reflection as well on how to take the length of a child, but in this particular situation, the child is standing up. So in this picture, once again, the man is the one taking the measurement. He's standing on the right side of the scale. He is near the actual tape measure on the side so that he will be able to read the measurement properly. The woman is the assistant. As you can see, the woman is holding the knees of the patient so that she can ensure that the child's back is as flat as possible on the height board. The left hand on the knees, and the knees are together, and the feet are firmly planted on the foot plate so that the child is standing as straight as possible. And then once again, the line of sight should be as perpendicular as possible to to the height board. So next slide, please. So in this particular situation, we ask, is this position correct or incorrect? So we'll do a quick poll once again. Is this correct or incorrect? Kindly indicate your answer if you think the technique being shown is correct or incorrect. Okay, 5, 4, 3, 2, 1. We'll close the poll now. And Alex, if you kindly click for the next slide. So this technique is incorrect. So as we can see in the poll that 96 of our participants were able to identify it correctly. Strictly speaking, the technique itself is not a problem because the person taking the measurement is making sure that the child is looking forward and the child is not moving. But as you can clearly see, the child is not comfortable at all. And we don't want this particular situation to happen. We want to make sure that the child is comfortable, and it's also part of establishing rapport with the child, because you're not just going to take the length or the height, you're also going to be taking other measurements. So if you hold the child in this particular position, the child might not be as cooperative in the next when you take the next measurements. So next slide, please. So in this case, once again, is this position correct or incorrect? So we won't be doing a poll anymore, just in the interest of time. But very clearly, is the technique correct or incorrect? So we very much stress that the feet of the patient should be flat on the foot plate. So as we can see, the child is tiptoeing, and as we know, when we take the measurement, the child should not be tiptoeing. So this technique is incorrect. The assistant in this slide should be making sure that the feet of the patient are flat on the foot plate. Next slide, please. Correct. Okay, so for this one, let's do another poll. Please kindly indicate on this, referring to the picture on the screen. Can you comment if the technique being used is correct or incorrect? So we'll give a few more seconds for the people to place their answers. Is this correct or incorrect? Ten more seconds. And we'll be ending the poll in 5, 4, 3, 2, 1. Okay, so we'll end the poll now. And is the technique correct or incorrect? Alex, can you click, please? So the technique is incorrect. And we can see from our poll that 92% of our participants were able to identify that the technique used is incorrect. So we'll go into the reasons why this particular situation is incorrect. So as we can see, there's only one person who is taking the measurement. So it's actually, the child is very well behaved again, but as you can see, there's already an indication that the child is not in the proper position for you to be able to take the measurements. There's no partner here. So there's only one person doing all of the tasks needed in order to measure correctly. So it's going to be very cumbersome. You can see that the child's neck is not straight and the head is not facing forward. So there's going to be a discrepancy in terms of the measurement. And then the feet are also not not flat on the foot plate. Even if the attention of the person taking the measurement is clearly on the foot, in this particular point in time, this snapshot, the foot of the child is not straight, it's not lying flat on the foot plate. So if this person is taking the measurement right now, then she will not get an accurate measurement of the child's length. Okay, so next slide, please. Okay, so just to recap very quickly, we've done the age, we've done weight, we've done height and length. So these are individual measurements, but we have to put all of these together. So and this is where this particular concept, the Z-score, comes in. So it's not enough for us to be able to take these measurements individually. We have to be able to compare them with a standard. So in order for us to be able to determine if the child is is well known, what to determine what the child's nutritional status is. So what is the Z-score? The Z-score is a way to compare a child's weight for length or weight for height to an average or to standards. And for this particular, for the Z-score, we use the WHO Child Growth Standards table. And we flash it on the screen. Normally, we apologize because normally during these particular trainings, we provide you with copies of these growth standards on laminated cards. Unfortunately, this is not the case, but we'll just show you the examples of these cards in order for us to be able to see why these scores are important. It's important for us, firstly, to know that when you use these child growth standards, you have the reason there are different kinds, specifically classified according to the child's age and according to the child's sex. So once again, these are why these were stressed earlier on. So this might not be, I know that this is not politically correct anymore, but for sake of simplicity, when I think these cards were developed in 2013, these particular cards, the blue ones indicate for males, or for boys basically, and the pink ones are for girls. But you also have to determine the child's age in months, because you have to know if its child is 0 to 23 months or 24 to 60 months. So depending on the child's age and the child's sex, you have to pick out the right child growth standard card, and then that is what you will use to see and compare the measurements that you got, if how they fare in contrast to the WHO standards. So next slide, please. So I apologize in advance for this, but this is a bit of a crash course in terms of a bit of statistics, but don't be afraid of this because this is actually very, very straightforward. So this is a curve indicating the weight for height for girls 2 to 5 years of age. So once again, we stressed earlier on that you have to identify the child's sex and the child's age. So for this particular example, we'll be using the child growth standard for females whose ages are from 2 to 5 years old. So what was done here is that the WHO made these standards in such a way that if you plot the weight and the height of a child, you will be able to, on this particular graph, you will be able to compare it to standards across the globe. This is, of course, there are certain limitations to that because this is global standards, and of course, it would be better to use standards that are locally available. However, this may not be present in all countries. So, for example, in the Philippines, this is the particular set that we are using. As you can see on this chart, on the left-hand side or the y-axis of the graph is the weight of the child, and on the bottom or the x-axis is the height of the child. So once you're able to get the weight and the height of a child, then you plot it like you would do on any normal graph. And as you can see, there are certain lines, certain curves on the screen. I'd like to first draw your attention to the green curve, which is the 0. On the 0, basically what it means is that this is the normal measurement. So whatever the weight or the height is, the closer you are to the green line, that means that you are closer to normal. However, the other measurements, as you can see, that there's a red, there's orange, and there's certain numbers that correspond to it. If you fall within these particular spaces, that's when you can determine that if the child is demonstrating any degree of malnutrition. So for example, in this particular case, I'd like to draw your attention to the red curves, the 2 and the -2. So from the green curve up, from the green curve of 0 up to the red number 2, if the weight and the height of the child is plotted anywhere in between 0 and 2, it is still considered normal. And on the other extreme, if it's in between 0 and -2, it is still considered normal. So I know this might be a bit a lot to take in, and we would want to take more time for this, but we'll have to do with this particular setup for now. What we need to know also is that so from in between -2 to 2, that is considered normal. But once it becomes from -2 to -3, then that is considered that child may be demonstrating wasting already. And then if you plot the point below the line of -3, then that becomes severely wasted. So Alex, if you could kindly click the slide, please. I know that this is not as easy to comprehend as the previous slides, but once again, just to recap, if you get the weight and the height of the child and you plot it on this particular graph, and it's between -2 to +2, then that child is considered normal has a normal weight for height. But if the weight and the height of the child that you are measuring falls in between -2 to -3, then the child can be classified as having MAM or moderate acute malnutrition. And if the child if the plot of the graph falls below -3, then that child is identified to have severe acute malnutrition. So it's a lot to take in, and it's much better to do this face to face. But if you'll indulge me, we'll go to the next slide. This particular graph is actually translated more easily into the tables that we were showing earlier. So this particular slide is actually also exactly the same representation as the pictures as a graph that we were showing earlier. So as you can see here on the leftmost side of the chart is the height of the child. The y-axis corresponds to the height of the child, and the x-axis this time corresponds to the weight of the child. And you can see that the height is delineated by 0.5 centimeters, and the weight of the child is classified into different columns, but it's actually the same as what we were discussing earlier, that the normal measurement is from -2 to +2, and then if the child is wasted, it's from -3 to less than -2 standard deviations, and then if the child is severely wasted, it's less than -3 standard deviations. So I know it's a bit a lot to take in, but we'll do an example just to walk us through and try to make this Z-score more understandable. So next slide, please. So just to remember, again, if the measurement falls from -2 to +2, the weight for height or the weight for height or the weight for length score is normal. If it's less than -2 to -3, then it is moderate acute malnutrition. And if it's less than -3, it is severe acute malnutrition. So let's go to an example. Next slide, please. Sorry, before we go into the example, once again, we emphasize that you have to take note of the child's sex and determine the child's age in months, because it will allow you to pick the proper card that we will be using for the example that we are doing. And one more thing to note, once you get the proper height, you have to round off the measured length or the height of the child to the nearest 0.5 centimeters. So if we will be going back to the chart later on, but as you can see in the height, you will see in the height, the measurements are by increments of 0.5 centimeters. So next slide, please. So this is a bit tricky because it's not. This doesn't follow the normal mathematical way of rounding the numbers off, such that if it's there's a certain way of rounding it off. You have to round off to the nearest 0.5 centimeters. So, for example, if mathematically, in normal math, if for example, if you have a value that is 81.4 and you have to round down, then by normal mathematical rules, you will round it down to 81.4 is rounded down to 81.0. But in terms of nutrition, you have to round it to the nearest 0.5 centimeters. So for example, in this particular example that we used, if it's 81.4, you have to round it up actually to the nearest. You have to check if it's near to 81.5 or if it's near to 81.0. So I know that this is getting a bit more unwieldy, but for the example here, what we say here is you subtract subtract or add 0.2 centimeters up and down from 81 centimeters to get the lower and upper limits so that you will be able to measure it. So for example, if you get a measurement that is 80.8, 80.9, 81, 81.1, or 81.2, when you plot it on the z-score on the chart, you have to report this as 81. In contrast to if you have a measurement that is 81.3, 81.4, 81.5, 81.6, 81.7, you have to round it to the nearest 0.5 instead. So I know that this can be confusing, but it's just a matter of being able to round it to the nearest measurement if it's 0.0 or 0.5. So we'll use an example later on in order for us to be able to see how this example works in real practice. Next slide, please. So steps in determining the z-score. So we do this after measuring the weight and the length or the height. So once again, we have to first check if we're using the proper growth standard table. So for this particular exercise, please indulge us in this exercise. We'll be using this example where we have a 25-month-old boy with a length of 66.0 centimeters and the weight of 6.3 kilograms. So use the child growth standards form for boys ages 24 to 60 months. So normally we'd be asking you to take out your particular table, but we've done this on the screen. You're looking at the CGS chart for boys ages 24 to 60 months. So what you first do, you have this data, you have a 25-month-old boy with a length of 66 centimeters and a weight of 6.3 kilograms. So you have to see where this particular child's measurements are located on the table. So as you can see on the screen, there's a red line on it, and it's right below the value of 66, because we're looking at the measurement of the child who has a height of 66 centimeters. So Alex, if you can please click. So once again, we're just in the values in the box refer to the columns where we look if it's severely wasted or normal. So as we can see here, the value of 66 is highlighted because we're looking at the boy with a length of 66 centimeters. And you can see the arrow, the weight of the child is 6.3 kilograms. So as you can see in this particular example, Alex, next slide, please. The measurement is in between 6.0 and 6.4 measurement in that particular range. So that is why when you put it all together, 6.3 kilograms is between 6.1 and 6.4. So the z-score of this particular child falls between -3 and less than -2 standard deviations, which, as we can see indicated here on the table, falls under the category of wasted or moderately wasted, basically. So putting everything together, this 25-month-old boy, we use the child growth standards of 2 to 5 years old, and for males, we've determined that the child's length is 6 centimeters and the weight is 6.3 kilograms. And when we put everything together, we can see that the child's measurement for the z-score is located in the column for wasted, so that we can say that this child is wasted or moderately wasted. So there, that's just an example for this, and I know that it's not as straightforward to follow, but bear with us as we try to go through this through another exercise. So Alex, next slide, please. So for this particular situation, the child is moderately wasted or has MAM, or moderate acute malnutrition. Next slide, please. So let's do this. Let's do another exercise. A 32-month-old girl's height is 95.3 centimeters and their weight is 10.0 kilograms. What is her weight for height z-score? So once again, let's just run through the steps. So firstly, we have to secure the correct WHO child growth standards table for age and sex. So the child's age is 32 months and the child's sex is female. So that's why we're using this particular child growth standard table. We already placed it on the screen for your reference. So this particular example is not as straightforward because the child's height is 95.3. So we have to do a bit of rounding off to the nearest 0.5 centimeters. So mathematically, if we round this off, it would be 95.0. But since what we are doing is we are rounding it off to the nearest 0.5 centimeters, this value is closer to 95.5. So that's why that is the value that we will be using. We round off 95.3 centimeters to 95.5 centimeters. And then afterwards, now once we've identified the height, now we use the weight, where we check where what the child's weight is, and we can see that the child is 10.0 kilograms. So we try to locate where this is located. We try to see where this is located on the table. So Alex, if you can click please for the next slide. So the red line indicates the line for the height of 95.5 centimeters, and we try to see where 10.0 kilograms is located. And as we can see in the column for severely wasted, the smallest value is actually 10.7 kilograms already. So that's actually higher than the value that we have for that the child is showing. So that's actually a clear indication of what basically the measurement of the child's weight is much less than that. So you can see that that child's Z-score falls under the column of severely wasted. So Alex, if you can click please. So it's less than 10.7, one more click. So you classify the nutritional status of the child as severely wasted, and you record this, and you record the Z-score as less than -3 standard deviation. And the assessment for this child, as you are correctly noting in the chat, is, Alex, one more click please. The child has severe acute malnutrition based on the weight for height Z-score. Okay. So normally we would be doing a lot more examples, but unfortunately we do not have time for it. We are restrained by the format of this webinar. So next slide please, Alex. So just to recap, if the Z-score of the child is from -2 to +2, then the Z-score is normal. If it's from less than -2 to -3, then it's moderate acute malnutrition. If it's less than -3, then it is severe acute malnutrition. Okay, so next slide, please. So we just have to put this caveat here, because we know that, for example, that SmileTrain uses different parameters in terms of determining whether a child is ready, it can be operated on or not. From what we were informed, according to the patient weight requirements and the safety and quality protocol, it requires that patients are of age-appropriate weight and a minimum 5 kilograms in order to receive a safe surgery. And this is important, of course, coming from a medical background, this is completely understandable as well, because you can't just operate on any child. You have to make sure that the child's nutritional status is correct before you decide whether you can operate on the child. But what we have to emphasize here is that in determining operability, there's a slight difference in terms of what we use in measuring in contrast to what we've been discussing in this particular lecture. So next slide, please. So for in determining operability, what SmileTrain is using is the age, is the weight for age. And from what I understand and what was shared with us, there's actually a calculator that can easily calculate whether the child is qualified for surgery. But as you can see on the screen, you just have to input the date of the birth of the child, and also the weight, and also the sex of the child. And once you click it, it can determine whether the child is severely underweight, normal weight, or overweight, or it can easily determine whether the child is what is the child's weight for age status is. But we have to emphasize that this particular application measures the weight for age. What we have been looking for example, in the Z-score measurement, is weight for height. And we'll go into more detail on this on the next few slides. Next slide, please. So we have to delineate what the differences are between the weight for age and the weight for height. So in this particular setting, this particular graph, the letters on the screen indicate the measurements, different children with different anthropometric measurements. So if you'll indulge me, the red curves on the screen are the values indicated in between the red curves are of normal weight for age. So as you can see, the children labeled as A, C, H, I, J, M, N, in between the +2 and the -2 red lines, they are considered normal weight for age. Those who are above the line of above +2 are considered overweight or overweight to obese, and those under -2 are considered underweight. So this is for weight for age. We just want to this example is necessary because we want to see the differences when we take into consideration weight for height. So next slide, please. So this one actually, as you can see, normally it should follow that those who are normal in weight for height should be normal in weight for age. But actually that is not the case, as we can see on the screen. So in this particular example, those who are in between the blue lines, basically the children who are labeled K, H, L, I, E, J, and G, these are the ones who are considered as having normal weight for height. And those who are above the +2 line, the ones who are A, B, C, D, F, those are considered overweight to obese in terms of weight for height. And those who are below the -2 line, the -2 blue line, are the ones who are O, P, M, N, and Q. These are the ones who are considered wasted. So the thing that we need to point out here is that there are children who are considered normal in weight for age who are not considered normal actually in weight for height, and vice versa as well. In particular, for example, let's look at the children who are the children labeled M and N. If you look at these children, they fall the child labeled M and N. They fall in between the red lines. So if you take the weight for age, they're actually considered normal in terms of weight for age. But if you consider that you consider the measurements in terms of weight for height, they're actually falling below the -2 line. So they're actually showing up when you take their weight for height Z-scores, they are showing as wasted or acutely malnourished. So as you can see, there are some discrepancies here between taking weight for age and weight for height. So we just want to emphasize that as we go along in this particular lecture. But we have to note that we are not saying that the weight for height should replace weight for age as the operational criteria, because this definitely needs to go into further discussion. But we just want to emphasize here that while these different measures, the weight for age and the weight for height, are measures of nutrition, they are not necessarily measuring the same thing. When you take weight for age, you're measuring more of the child being underweight or overweight. But when you do weight for height, you are testing more for wasting, whether the child is moderately wasted or severely wasted. So you have to be careful it does not automatically follow that when the child is normal for weight for age, or whatever the value is for the child's weight for age, it does not automatically follow that is the corresponding value when you go to the weight for height. So we just wanted to highlight that we're not saying that we're replacing the criteria for operating on children. Definitely still stick to the weight for age, because that's already been established. But we just want to avoid any confusion, because in this particular setting, when we're looking at malnutrition, we are looking at weight for height. So next slide, please. So we'll just go through this quickly also as well. This also applies to length or height for age, that it does not follow as well. That some people who have normal length or height for age may not have normal weight for height as well. So we'll just proceed with the next slides. Okay, so that's just the thing that we want to emphasize on the Z-score. The Z-score takes together the age, the sex, the weight, and the height of the child. And when you put all of those together, you will come up with a value that will be able to let you determine if a child is malnourished or not. So that is one measure that we are using. But now we will go on to another measure, which is the mid-upper arm circumference. And the mid-upper arm circumference is actually quite straightforward. And I know that a lot of health workers here are already familiar with it. It is basically we use this as a measure in children older than 6 to 60 months of age, and it's a simple measure of muscle wasting. It's an independent measure of severe acute malnutrition, and strongly predicts risk of dying from severe acute malnutrition. And as you can see here on the screen, we use this it's not showing up, sorry, because of the white background, but we use this particular device called the MUVAC tape, the mid-upper arm circumference tape, we use this to take the measurement of a child, and we will be demonstrating how to take this measurement in the next few slides. So next slide, please. So firstly, of course, when we take the measurement, we have to we take the measurement of the left mid upper arm of the child. So it's not as easy as taking this piece of tape and wrapping it around the arm of the child and just taking the measurement anywhere. You have to be able to determine the right place where you will take the measurement first. So in this particular example, we will be going through the steps. First of all, you palpate the tip of the shoulder. There's a bony prominence on the shoulder of the child where what will you be using as the first point of measurement in order to be able to determine the midpoint of the upper arm. So you always measure the left upper arm's midpoint between shoulder and elbow. It does not matter. At this point in time, the child might not be showing preferred handedness at this point in time, but for the sake of uniformity, we will, regardless of the handedness of the child, you will be using the left hand just to make the process standardized. So you palpate the tip of the shoulder. Next slide, please. And you measure it with the elbow bent at the right angle. So you use the landmark of the tip of the shoulder. You always measure from behind using the left arm. You palpate the tip of the left shoulder, and you palpate the tip of the bent elbow. And then you measure the distance between these two landmarks divided by 2, and that is how you determine the midpoint of the upper arm. So usually you do this with an assistant as well, who will be the one marking the spot. So just very quickly, in this example, if the measurement from the tip of the shoulder all the way down to the tip of the elbow is measured as 15 centimeters, to get the midpoint, you divide the value of 15 centimeters by 2, and you will get 7.5 centimeters. So the assistant will mark the 7.5 centimeters on the child's arm, and that is where you will be wrapping around the mid upper arm circle, the MUAC tape. You will be measuring the MUAC at this level. So next slide, please. We will just be going into a few more examples on this. The next slide. So once again, just to recap it. So steps in taking the MUAC: you take the length of the mid upper arm. You determine the midpoint of the upper arm by going through the next steps. Alex, next slide, please. Next slide, please. So you measure the tip of the you measure from the tip of the shoulder until the tip of the bent elbow. Next slide, please. Oh, sorry. You measure from the tip of the shoulder until the tip of the elbow, and then you get the value of that, and you divide it by 2. That is where you will be measuring the circumference of the mid upper arm. So next slide, please. So with the left upper arm straight and the elbow bent at the right angle, use your finger to palpate the child's shoulder from the rear. So you will be in clinical nomenclature, you will be measuring the acromion. You will be feeling around from the shoulder of the child. You look for the bony prominence on the left arm, and that is the point where you will be starting the measurement. Next slide, please. Feel the bony prominence as marked by A next to a gap. You will actually, when you feel the bony prominence, when you move it around, you will feel a gap next to it, and that is how you can determine if this is the proper position that if you are using the proper starting point. Next slide, please. So the bony prominence is the tip of the shoulder, and even if you ask the child to move around the arm, this point will not move while moving the child's arm. So that's one way of determining if you got the right spot for the starting point of taking the MUAC. Next slide, please. So when using the MUAC tape, we just have to go through this just in terms of what it looks like. As you can see, there's a window here with the arrows indicating it here. As you can see, this is actually pretty much just like a ruler. The arrows align to the 0 centimeters, and it goes all the way until certain measurements, so that you will be able to measure the circumference of the mid upper arm. Next slide, please. But you have to be familiar with how to use it. You have to make sure that when you use this the MUAC tape, you will be putting this particular end. The end will go into not into this window, but it will be going into the slit as indicated on the screen. So here, this is where it will be going through. The window is basically just used for you to read the measurement. Do not make the mistake of putting it through the window, but you make sure that you put that tip through the slit. And so, for example, normally it would be so much easier if there was a child who we would be measuring. So here, as you can see, once you put it through the slit, and you can see that it moves, you can move the MUAC tape around, and it will basically constrict around the upper arm. And then you can see the corresponding measurement as determined by the arrows to see if the child will be considered as having severe acute malnutrition or not. So next slide, please. So firstly, we have also just to make sure, the MUAC is only used for children who are or older than 6 months of age. If the child is less than 6 months of age, the MUAC is not applicable, and you use the weight just use the weight for length Z-score instead. So the MUAC is only used for children who are older than 6 months of age. So next slide, please. So when you take the measurement, of course, you have to make sure that the child is comfortable or cradled by the guardian. You position yourself to the child's rear, and you measure once again the left arm. Next slide, please. So for this child, the length of the upper arm, for example, measuring from the tip of the shoulder up until the bent elbow, in this particular setup, just take the example provided here is the length of the upper arm is 20 centimeters. And to determine the midpoint, you divide the length of 20 centimeters divided by 2, and then you get 20 centimeters divided by 2, which is 10 centimeters. So for example, if this is a line, sorry, I know that this is not ideal, but when you measure it like this, and then you try to determine where along the arm the measurement of 10 centimeters is matched, and then you mark it on the child's arm, and that is where you put the MUAC tape around the child's arm to get the circumference. When you take the midpoint, the arm of the child is bent because you have to determine the tip of the upper arm and the end of the elbow, the point of the elbow. But when you take the measurement, the whole arm has to be straight. You have to make sure that when you take the midpoint, you bend the arm at the right angle. But when you are taking the actual measurement of the MUAC, you have to make sure that the arm is straight. It is straight already. So next slide, please. So just to remind ourselves, in the same way that there are certain parameters for the Z-score, if it's -2 to +2, it's normal. If it's less than -2 to -3, it's MAM, and less than -3, it's SAM. In the same way, there's a corresponding value for the MUAC. If the MUAC value of the child is greater than or equal to 12.5 centimeters, then the MUAC value is considered normal. If the value is from 11.5 centimeters to 12.4 centimeters, the child is considered to have moderate acute malnutrition. And if the value is less than 11.5 centimeters, then the child has severe acute malnutrition. So depending on the measurement that you will get, sorry, I know, once again, I apologize for this, but if you take the measurement and you see once you take the measurement that the value is as indicated here. Actually, just to note also that this is color coded just to make it easier, but it's more important for you to rely more on the values because some MUAC tapes are not color coded. So just to make sure, just to note that. But if the measurement of the MUAC falls in the yellow space, which is from 11.5 centimeters to 12.4 centimeters, the child is considered to have moderate acute malnutrition. But if the child has less than 11.5 centimeters, it corresponds to the red part, and as correspondingly, it indicates that the child has severe acute malnutrition. So next slide, please. So sorry, I know that's a lot again to take in. It's a lot easier to do it firsthand. We do our return demo normally, and unfortunately, we are not able to do that properly, so that I cannot see if you are able to to demonstrate this technique to see if you grasp the concepts properly. But just to recap, the mid upper arm circumference is a parameter that we use in order to determine if the child has severe acute malnutrition. It's independent of what we talked about earlier in terms of weight for height. Basically, the MUAC measurement also is another indicator that we use to determine the child's nutritional status, and in order for us to properly determine if the child has severe acute malnutrition or not. So to recap, we've gone through weight for height, we've gone through the MUAC. Now we will go to another parameter, which is testing for edema. So next slide, please. As indicated earlier, the edema is actually more of a clinical sign or a symptom, where the definition is that there's a large amount of fluid that gathers so that the tissues look swollen or puffed up. And as Dr. Donna mentioned in the previous lecture, bilateral edema is a sign of kwashiorkor, or a severe form of malnutrition. And it's important for us to be able to determine if children who are edematous, because they are at a higher risk of dying and need to be treated in a therapeutic feeding program urgently. So next slide, please. So in order for test for edema, we have to note that we are looking for edema that is a bilateral pitting edema. It has to be on both sides. It has to be demonstrated on both sides of the body. That's why it's called bilateral. If it's just one foot or just one side of the body showing it, the cause of the edema is most probably not nutritional. So in order to test for edema, what we do is we look at the child's feet. And what we do is we get both feet at the same time. We use both hands and apply normal thumb pressure for at least 3 seconds on the dorsal part of the foot. If a shallow print persists on both feet, we record this as having positive edema. So what we do is we get the feet of the child. We count, and we do it, and we're not ashamed to count aloud, because we just to make sure that we do it properly. So we put our our thumbs on the feet of the child, and we count 1001, 1002, 1003, and then we let go. So as we can see in this particular set of pictures, after release of the thumbs, there's still an indentation on the child's feet. And it's not just on one foot, it's on both feet of the child. Even after 3 seconds and after considerable time, the depression still persists. So this is evidence that the child is demonstrating that the feet have edema, and edema on both feet or bilateral edema is consistent with nutritional edema. And just to emphasize the points further, next slide, please. We also have to take into consideration that edema has grades. That because you also have to properly identify the grading of the edema. If the edema is only located on the feet, you classify it as having +1 edema. But if the edema reaches up to the legs, as you can see in the middle picture, where up to the feet, the legs, and maybe even until the hands or the lower arms, this is classified as +2 edema. But if the edema is all the way until even the face of the child, as we can see in the third picture, where the entire body of the child is demonstrating that he or she has edema, then the grading of the edema is +3, where both feet, the legs, the hands, the lower arms, the upper arms, and the face as well are indicative that the child has edema. And this is a serious sign that the child's nutritional status is compromised. So next slide, please. So just to run through the process again, in this particular situation, we just want you to comment. We won't be using a poll anymore because in the interest of time. Is this method correct? We can see that the examiner here with one hand is pushing on the left foot of the child. Kindly indicate if you think that the technique is correct or not. So we'll just be a few more seconds, but I can see that as indicated in the chat that everybody agrees that this technique is incorrect. And Alex, kindly click please for the next slide. Oh, okay. Okay, sorry. Just, go back, please. This method is incorrect because once again we have to highlight that the the investigator is not looking at both feet of the child. He's only using one hand, and also he is using the investigator is using the index finger. You are supposed to use the, yes, as properly as indicated in the chat, you have to use the thumb. So you use both thumbs, you use both hands, you use both thumbs of both of your hands on both feet of the patient to determine whether the patient has edema or not. So I know that not everybody in this webinar may have had experience in identifying in seeing people with edema firsthand. It's actually one of those situations that actually I'm pretty sure that if you see a child with edema, especially as you saw in the pictures earlier, it's something that you don't quite forget, and it's something that will be stuck in your mind for quite some time. But for those who have not experienced it yet, it's important for us to be able to still determine the proper technique so that we know if we can properly identify if the child has edema or not. So next slide, please. So putting everything together, these parameters, the MUAC, the weight for length or the weight for height Z-score, and the edema, these independently are able to tell us if the child has severe acute, are able to tell us if they're able to help us determine the nutritional status of the child, whether it is normal, whether the child has MAM, or whether the child has SAM. So for the MUAC, once again, let's just recap. If the value is greater than or equal to 12.5 centimeters, it is normal. If it is MAM, it is 11.5, in between 11.5 to 12.4 centimeters. And for SAM, it's less than 11.5 centimeters. For normal, for weight for length or weight for height Z-score, the normal value is from -2 to +2 standard SD. For MAM, it's from less than -2 to -3 SD. And for SAM, it is less than -3 SD. But for edema, if the child has no edema, it can be considered as normal or having moderate acute malnutrition. But if the child has edema present, it is automatically an indication that the child has SAM. So whether you have +1, +2, or +3 bilateral pitting edema, as long as the child shows that he or she has edema, the child is automatically considered as having severe acute malnutrition. Take note that this is bilateral pitting edema. You have to use both. You have to see that there's edema is demonstrated on both feet of the child, on both sides of the body, and not just. And you also have to use the proper technique because otherwise the edema might be caused by another illness or whatever. So you have to make sure that you are using the proper technique in whether identifying if the child has edema or not. Next slide, please. So, sorry, just to indicate for the previous slide, that was for children 6 to 59 months of age. But this particular slide is for children who are less than 6 months of age. And as you can see, it still indicates weight for length, Z-score, and edema. But as you can see, MUAC is absent because MUAC is not used for children less than 6 months of age. It's only used for children 6 months and older. In our particular setting, from 6 months to 59 months of age. The next slide, please. So putting everything together, you can now actually identify if a child has severe acute malnutrition, moderate acute malnutrition, or of normal nutritional status. So once you identify the nutritional status of the child, what is next? Basically, you have to properly classify the child and where do you have to refer the child in order to get the proper treatment. This is just touching on the subject, and this will be discussed in further detail tomorrow. But if the child has moderate acute malnutrition, you refer the child to a targeted supplementary feeding program. If the child has severe acute malnutrition, but without medical complications, you can refer the child to outpatient care. And it's only if the child has severe acute malnutrition with medical complications, that is when you refer the child to inpatient care. So this is a stark contrast to how the old protocols used to do it, in that before, if there was any indication that the child had malnutrition, the child would automatically be admitted to inpatient care. But that is one of the thrust of CMAMI, the thrust of CMAM, where we want to be able to to unburden the hospitals and the health facilities, and that we can see that even if severe acute malnutrition can be treated on an outpatient care basis as long as there are no medical complications. So that's why this highlights even further the need to properly identify the child's nutritional status in order to be able to triage and refer the child accordingly to where the child will be able to get proper treatment. Next slide, please. So we've gone through MUAC, we've gone through weight for height, we've gone through edema. One more test that we use in identifying the degree of malnutrition is the appetite test. So as you can see on the screen, the loss of appetite is the best sign of severe metabolic malnutrition. And the appetite test is a critical part of the assessment of the child with severe acute malnutrition. The product that you see on the screen is what we call the ready-to-use therapeutic food. It is a mainstay of treatment that we use for helping to rehabilitate children who are diagnosed with severe acute malnutrition. The appetite test helps distinguish whether the child with SAM needs a referral to outpatient therapeutic care or inpatient therapeutic care. So what we are saying actually is that loss of appetite, if the child is if the child is given is given RUTF and does not demonstrate appetite, then that is an indication that the child should be referred to an inpatient facility, because that is considered a severe complication and the child needs the most urgent medical care immediately. So next slide, please. So in terms of instruction on how to give this, we explain to the caregiver and why the appetite test is done. We have to observe proper hygiene standards here. We instruct the caregiver to wash hands properly. We sit the caregiver and the child in a quiet space, and you have to be there to observe the process to make sure that the child that the process has been administered properly in order to determine the presence or absence of appetite. You have the caregiver offer a small amount of RUTF on the finger or direct. So the caregiver will squeeze an amount of RUTF on the finger for which the child will get to eat, or the child can directly eat from the sachet itself. So next slide, please. While the child is undergoing the appetite test, offer water or breastfeed after the child takes RUTF. If the child is not taking it, gently encourage intake, but do not force feed the child, because you are assessing if the child has appetite or not. So you want to see how the child is reacting in real time, whether the child is demonstrating appetite or not. So you also have to record the amount that the child has eaten. So next slide, please. So you consider the child as having passed the appetite test if the child takes 3 or 4 mouthfuls or more of RUTF over a span of 1 hour. So it takes a bit of time to observe this, because it does take rapport, of course, because the child may not readily demonstrate appetite firsthand, because especially since it might be the first time that the child is in this particular setting, and it might not be comfortable. So you have to take your time in this particular process to determine if the child has appetite or not. So if the child is able to take 3 or 4 mouthfuls of RUTF, that is considered a pass. But it is considered fail if it's less than 3 to 4 mouthfuls of RUTF. She or he is considered to lack sufficient appetite for OTC and should be referred immediately to inpatient therapeutic care. A lack of appetite, once again, is a sign of severe form of malnutrition. So you need to refer this child immediately to inpatient therapeutic care. So next slide, please. So here we have a quick video just to, sorry, if we can go back. There should be a video here. If I'm not sure if it's up. Okay, there we go. So if we can please quickly play this short video.
The appetite test should be conducted in a separate, quiet area. Explain to the caretaker the purpose of the appetite test and how it will be carried out. The caretaker should wash their hands. The caretaker should sit comfortably with the child on his or her lap and should either offer the ready-to-use therapeutic foods from the packet or put a small amount on his or her finger and give it to the child. The caretaker should offer the child the ready-to-use therapeutic food gently, encouraging the child all the time. If the child refuses, then the caretaker should continue to quietly encourage the child and take time over the test. The test usually takes a short time, but may take up to 30 minutes. The child must not be forced to take the ready-to-use therapeutic food. The child needs to be offered plenty of water to drink from a cup as he or she is taking the ready-to-use therapeutic food.
So as we can see, the video is quite simplistic, but it tries to demonstrate the difference between a child having appetite, where if the child is malnourished, but you give the RUTF, the first child readily took the food and demonstrated that he or she had appetite, in contrast to the other one who needed to take some time before he or she could demonstrate if he or she had appetite or not. And in this particular situation, it was considered that the child did not have appetite, and as such, that child needs to be referred to inpatient therapeutic care for closer observation and immediate treatment. So next slide, please. So just again to highlight, if the child fails the appetite test, you need to refer the child immediately. And we just want to highlight here that when we go through the program, there's a lot of forms actually involved, but we just want to highlight that there's a intricately connected pattern web of referral that needs to happen. So if once you identify that the child has failed the appetite test, you need to fill up this form and immediately refer that child to the proper facility in order to get the immediate treatment necessary. So next slide, please. So, okay, let's try to put everything together once again. And let's use this particular example of a child. So, putting everything together putting everything that we know for edema, for MUAC, for weight for height, for age, sex, etc., let's try to determine the nutritional status of this particular child. So in this setting, we have a 48-month-old boy. The weight for height Z-score is from less than -2 to -3 standard deviations. The MUAC is 13.5 centimeters, but there the child is showing grade 3 edema. So let's use a poll again for this particular question. This child has edema, this is a grade 3 edema. Let's see, what is your assessment for this? Hold on. So kindly indicate on the screen, kindly pick what do you think the nutritional status of this child is. If it's normal, MAM, or SAM. Just a few more seconds. 5, 4, 3, 2, 1, and we will end the poll. And now we will see. Alex, can you kindly click, please? The assessment is SAM. Because let's run through the criteria involved. So, in terms of we're looking, we already have the age and the sex of the child, so that's great. But when we look at the weight for height Z-score, the indication here is actually not SAM because it follows more in the class. It falls under the classification of moderate acute malnutrition. And actually, in terms of the MUAC, it's great. It's not less than 11.5 centimeters, and it's actually greater than 12.5 centimeters. So it's actually a normal measurement for MUAC. But when we look at the edema, it's grade 3. So that's a glaring indication that the child has severe acute malnutrition. And as correctly guessed by the participants, by the majority of the participants, 89%, the child has severe acute malnutrition. So as you can see, you take the different measurements, you take all of the measurements, but you have to put all of them together. You just don't take one measurement at a time. Sometimes the measurements may not be jiving with each other, but once there is an indication that the child demonstrates that he or she is having severe acute malnutrition, whether by weight for height, whether by MUAC, or whether by edema, the child is automatically classified as having severe acute malnutrition. So in this particular situation, the next step for this one is, since the child has grade 3 edema, what should you be doing? This child is basically the grade 3 edema is indicative of a severe form of malnutrition. So the next step for this child is, well, Well, sorry, I forgot, but this is basically a two-part question. But Alex, if you can please click just to go forward with this. You have to perform the appetite test to determine if the child has appetite or not. But since the child also has grade 3 edema, automatically you already refer to the inpatient therapeutic care because of the severity of the edema itself. If the child did also fail the appetite test, then it actually underscores that the SAM of the child is a graver problem actually. But at this particular point in time, even if you perform the appetite test and even if you pass the appetite test, because the edema is already grade 3, then the child is already considered as needing referral to the inpatient therapeutic care. So next slide, please. So very quickly, let's try to put all of these together. Just to wrap up this particular module, let's try to go through several exercises, and we'll ask you to determine what is the nutritional status of these children. So let's just go one by one for each example. We'll give you a bit of time, roughly 30 seconds roughly for each one. So let's go first with the first child, so whose name is Alvin, with an age of 48 months. The Z-score is from less than -2 to -3, a MUAC of 12.5, and no edema. So can you kindly share with us your particular answer? We will be putting the poll on the screen. Hold on. We will be putting the poll on the screen. And kindly indicate what you think is the nutritional status of Alvin. Okay, so 3, 2, 1, ending the poll now. So Alex, if you kindly show us the answer. So the patient is MAM. That is correct. As most of our participants were able to correctly answer, 96% of our participants indicated that Alvin has MAM. The indication is the Z-score, because by MUAC the measurement is normal. There's no edema. But the Z-score measurement is exactly what is needed for a assessment of identification of moderate acute malnutrition. So let's go to the next child. Let's go to Ben. So Ben is 24 months of age. Z-score of -2 to +2. The MUAC is 13.0. Edema is there is no edema. So let's see. Kindly place your answers on what is the nutritional status of Ben. Three, two, one, ending the poll now. And Alex, if you can kindly show us the answer. The assessment is normal, as also properly identified by 91% of our participants. So as we can see on the screen, the Z-score and the MUAC are indicative of normal measurements, and there is no edema, bilateral pitting edema. So the assessment of Ben is normal. So now let's go to Kathy, our third child. So with age in months of 35 months of age, a Z-score of -2 to +2, MUAC of 11.3, and no edema. So can you determine what is Kathy's nutritional status? Kindly indicate your answer on the poll. Three, two, one, closing the poll now. And Alex, can you kindly show us the answer on the screen? The assessment is SAM by MUAC. So in this particular setting, the majority of our participants answered MAM. And I think this is because of, well, the Z-score is normal, but the MUAC is less than 11.5 centimeters. So that automatically means that the child has severe acute malnutrition. So by virtue of the MUAC measurement, the child demonstrates severe acute malnutrition. Okay, so we go to our fourth example. let's go to Diego, who is 42 months of age with a z-score of less than -2 to -3, MUAC of 11.9, and a score of edema of +1. So kindly indicate if the child has, what is the nutritional status of Diego? So 5, 4, 3, 2, 1. We are ending the poll now. And Alex, if you could kindly show us the answer. Diego has SAM by virtue of edema, as this time correctly guessed by 76% of our participants. So even if the z-score measurement pertains to a z-score to a classification that is consistent with moderate acute malnutrition, and the MUAC is greater than 11.5 and less than 12.5, which is indicative of moderate acute malnutrition, the presence of grade 1 bilateral pitting edema automatically indicates that the child has SAM. So just to underscore that, if a child is presenting with bilateral pitting edema, automatically the child is considered to have severe acute malnutrition. And now we go to our last example of Ellen. So Ellen is 48 months of age with a z-score of less than -2 to -3, a MUAC of 11.7, and no edema. Kindly indicate your answer as to what is the nutritional status of Ellen. And we will be ending the poll in 5, 4, 3, 2, 1. And Alex, can you kindly show us the answer? And the assessment of Ellen is MAM by MUAC and the z-score, and 64% of our participants were able to guess it correctly. So actually, for most of the answers, the audience was able to properly identify the nutritional status of the children. And so congratulations for that. It looks like you have a very good grasp of the anthropometric measurements, but don't be discouraged, because I know that this is not something that you're expected to immediately get firsthand. It's something that a lot of people, regardless of your background, whether you are a community health worker or a doctor or a nurse, some of these measurements take time before you are able to properly understand the concepts themselves. But it's important for us to be able to at least have an understanding of what these anthropometric measurements are, and to be able to determine what the importance of each measurement is, and putting all of these measurements together in determining the whole and comprehensive picture of the nutritional status of the child. So let's go to the next slide, please, Alex. So we'll just watch this before we start the video. If you remember from the first lecture, Dr. Donna showed a short video of Jasmine, where she was identified to have a problem where she was suspected to have a problem of malnutrition. So as we can see in this particular video, we will be showing what happened next to Jasmine. So kindly play the video, please. So what it says on the screen is we will be accompanying Jasmine on her journey to the health facility. So kindly go back, please. So we will be muting the video because it's dubbed in Filipino, but just for the sake of our whole audience. So the family of Jasmine was brought to the facility. All of them basically were examined for severe acute malnutrition. As you can see, they're using, kindly see how the measurements are being taken and the instruments being used for the measurements. So these are the children involved in the families. And this is Jasmine, the one who was suspected to have malnutrition. And you can see the height is being taken, and the weight as well. And now the mother and the family is being brought into the doctor to be assessed by the health physician assigned to the facility. And actually, as you can see, these pictures were shown earlier. These are actually pictures of Jasmine. So as you can see, it's not a very pretty sight, of course. It's very disturbing to see a child who is demonstrating severe acute malnutrition. So as you can see, if you just look at the child with wearing clothes, it's very easy to miss out that Jasmine is malnourished. But as you can see, when you took the clothes off, the clinical signs were very much apparent. Please go on with the video. So as you can see, what's happening in the video here is that the doctor is telling the mother that Jasmine is definitely severely malnourished, and actually this is a peek also into bedside manners, because in this particular example, the health worker was a bit how do you say it, not so sensitive, because he was very straightforward in saying that that Jasmine had a very high chance that was in danger of dying, basically, and that's why you can see that the mother was very distraught. But what we want to emphasize in this particular video is that, as you can see, just by eyeballing Jasmine, it's easy to miss out that she is actually that she is malnourished. But when you take the anthropometric measurements of Jasmine, it very clearly indicated that she was having severe acute malnutrition. But at the same time, if you were able to see the instruments that they use and the techniques that they used, did they actually demonstrate what we were explaining in throughout this particular lecture? Firstly, they did not use the Salter scale; they were using a beam scale, and then secondly, for the height, they were using the another instrument. But frustratingly, you could see that beside the health worker, there was actually a height board. But most probably the health facility did not know how to use the height board. And that is why it was just relegated to being a stand for the instruments. So it's very important for us also to know the proper instruments that to be used, and to know when to use them in order to properly identify the children with malnutrition. And as also just to note from a clinical perspective, Jasmine's you can note that Jasmine, aside from being virtually skin and bones, you can see that her skin was already very shiny. You can see that her hair was showing discoloration. These are also signs that are indicative that definitely she has that there is a problem in terms of her nutritional status. So putting everything together, it's important for us to be able to determine the nutritional status of a child, because as we can see here, in the previous lecture, Jasmine was still at home. She was basically trying to drink water. She was trying to put on a brave face, even if she was actually, as we can see here, she was actually severely sick because she had severe acute malnutrition. And so it's very imperative for us to be able to determine the proper nutritional status of a child in order for us to refer these children and for them to get the proper treatment as soon as possible. So we go to our last slide. Just to recap our points for this lecture. So identification of SPAM and SAM is an important skill for all who work in health and nutrition, whatever level you are working on. And moderate acute malnutrition is known as moderate wasting. Severe acute malnutrition is known as severe wasting. And the classification of malnutrition to moderate or severe is dependent on anthropometric measurements. So that is why it's very important for us to accurately measure weight, length for height, determining the Z-score, and also measuring the MUAC. It's also important for us to be able to know that there are certain tests that we need to do to determine the severity of the nutritional status, such as the appetite test, which is critical in deciding whether a child with SAM needs OTC or ITC treatment. And more importantly, just to underscore that correct identification of SAM and MAM can save a child's life. It is important for us to be able to have a good fundamental understanding of anthropometric measurements and not to underestimate these basic skills, because these are things that sometimes we take for granted and we often overlook. It was not uncommon before for health workers to take measurements separately. Basically, you would have health workers take the weight and take the height, but there was no synthesis of putting everything together, because you need to have a proper understanding of how all of these measurements come together in order to determine the actual nutritional status of a child. You put together the weight and the height to get the Z-score, you take the MUAC, you take the appetite test, and when you get all of these together, that's when you can determine whether the child has a positive is showing in order to determine the nutritional status of the child. So with that, thank you for your attention. Once again, I would have much preferred to have this lecture face-to-face so that we could have a return demo of these techniques. But the expectation after this particular lecture is not for you to be able to do the techniques by yourselves, but for at least for you to know that these measurements are very much necessary in order for us to properly identify the children, a child's nutritional status, and then we put all of these together so that we will be able to put the information that we have to good use, especially in the lectures to come, in knowing how to properly treat children with moderate or severe acute malnutrition. So with that, thank you very much for your attention, and we will now proceed to our next part of our seminar, of our webinar. So thank you for that. I think at this point in time, we will now be proceeding to our open forum, where we will be answering questions from our participants. I would like to call on the different speakers for Dr. Silvestre and Dr. Capili to please join me on the virtual stage. And as we try to answer the questions of the participants, the questions fielded by our participants. So please allow me to catch my breath for a moment after that long lecture. But ma'am, I still need to check the Q&A, but do we have any questions right on the get-go?
Thank you. If we can, like, at least the panelists raise, how do you say that? Indicate their clap hands or hearts in the responses to show our appreciation for Drew. Thank God your voice did not give out, but unfortunately you're also the moderator. Over the course of your talk, Dr. Donna and I have been answering some of the questions offhand, so that we could make space for more questions during over the next 20 or so minutes. So let me just start off, I think, with the question that I already answered. The question was how many of our preterms here in the Philippines are also malnourished, and I answered Ms. Villanueva's query already directly. But my answer was, we do not have national data for preterms who are malnourished, either at birth, meaning they are preterm small for gestational age, or preterms who develop malnutrition later in infancy. So we don't have national data. Hopefully, later on, maybe with the development of what is called the newborn registry, that we might have more info on the preterm SGA rate, which is basically preterms who are malnourished, as I figure the question was. And then, are you okay, Drew?
Yes, ma'am. I can take it. I can take
yes,
it now. Thank you very
over,
much, ma'am, for allowing me to
over
catch
to
my
you.
breath.
So that was one question that we already resolved offline.
Online, ma'am. Yes, ma'am. So once again, we thank the participants for sending in the questions. So we will be running through the different questions sent. So one of the questions asked was, this is actually in terms of supplies. So a participant was asking, also the same participant from earlier, Ms. Mary Mediatrix Villanueva, was asking, how can we help rural villages in need of weighing scales? So this is actually a supply question. And actually, I'm very happy to see that Ma'am Kimi was able to answer. For Smile Train Partners, this is something that we can support. And you guys are so lucky if you are part of a community that is a partner of Smile Train. But just to provide an answer, well, firstly, we have to also indicate that currently we are not affiliated with the program, so we are not capable of providing a qualified answer specifically, because it would be better if the government would be providing the answers. But from our time working on the program, there was an allocation for supplies for the different health facilities. And actually, the beauty of the CMAM program is, or the PMAM program, is that the instruments that we are using are not just used for CMAM. These are actually used for different programs as well. So these are actually fundamental and basic to other programs such as integrated management of childhood illnesses or just any other program basically in the facility. So there is an allocation for supplies, but of course we know in reality that is not always the case. So it's always welcome still for other partners to be able to provide supplies as well, and that's why we're very thankful for Ma'am Kimi's input for this. Ma'am Kimi, do you want to add something on this topic?
Yes, I wanted to mention, thank you, Dr. Drew. Very hardworking. We're getting a lot of positive feedback from your lecture. I just wanted to point out, in the context of SmileTrain, because as SmileTrain's mandate is really to focus on cleft-affected individuals, particularly in this discussion, babies and children. So for our partners of SmileTrain who are on this call or on this webinar, we would be happy to have a discussion with you on how we can support providing better nutrition services for our patients. But I also wanted to add that we would like to put all of this into a broader context where, of course, I know Dr. Drew mentioned and Barbara made a comment also earlier in the chat where weight for age is not should not be the only measurement and is not the ideal measurement for when a surgery is supposed to be done, and that is true. And if you look at our safety and quality protocol, it is only one component of it. So there's like a minimum standard. We look at the weight, we look at the age, but there are also requirements that one, a physical exam is done by a trained pediatrician. That two, there are blood tests like hemoglobin, bleeding time, clotting time, etc. are required. Some of our partners require chest X-rays, etc. So all of these have to be factored in before a decision is made to do the surgery on a child. And ideally, this is done by a team of a pediatrician, the surgeon, and the pediatric anesthesiologist before a surgery can be decided to be performed. So that's, I just wanted to point that out. And I think that was one of the questions that came up also in the Q&A, if surgery can be done, if there are some factors missing or some factors that are present. So what we would encourage is that the surgical teams work together to be able to provide the proper assessment for the child receiving surgery. So.
Thank you very much, Kimi. So again, just to emphasize, it's not a one-person thing. It's not just one person deciding on how to properly treat the child. It has to be a team effort, basically, and it's putting everything together in order to be able to determine whether to proceed with surgery, and also on the front of nutrition, and whether to proceed on the path that you need to take in order to properly treat the child with depending on the identified nutritional status of the child. So we can go to some other questions, but some of these are related. So Ms. Nadine Casino, we would just like to acknowledge your question. Do you recommend all providers to have Salter scales and height boards so we can actually assess and screen our clients for the health status? So that's a very big yes, of course. In connection to our previous answer, definitely yes. Just a disclaimer of sorts. So basically, we are in the way that we're discussing this particular module is that we're showing a way of measuring of taking the anthropometric measurements of children. But of course, by all means, this is not the only way, basically. But what we are saying is that in our particular context, even the measurement, the instruments, and the technique is not equitable across all areas. So that's why in the program we are aiming to standardize and rolling out how to take the measurements and also the equipment used in order to properly identify the children's nutritional status. There are times where you might be limited with other resources. Not having a Salter scale, or not having a MUAC tape, or not having any of these instruments should not be an indication for you to not properly assess a child. But at least the technique involved, it's important for us to be able to appreciate this in order to still move forward in terms of the treatment. Dr. Donna, I saw that your hand was raised. Do you want to add something to the topic?
No, I think you just made the point that I wanted to make. Sorry, I can't. For some reason, my camera malfunctioned, so I can't show myself. But yeah, that is also the point that I wanted to make. No, it doesn't necessarily have to be the Salter scale per se, but it just has to be a tool or a measuring tool that is calibrated and that is measuring accurately. And the same goes for your height board or your length board. Okay, thank you, Drew.
Thank you, Ma'am Donna. Okay, so let's proceed to our other question. Actually, these some of the questions here are better suited for the program implementers to answer, but I think it's still very important for us to be able to touch on these issues. So there's a comment here from Michelle Medina that RUTF, or for ready-to-use therapeutic food, which is the mainstay of the treatment for severe acute malnutrition, is not always available. Are there any facilities who provide it? So we'll go more into the details for RUTF later on, but this is an issue that would be better answered by people, the program implementers. But yes, it's an acknowledged problem right now in the Philippines that unfortunately supplies are not readily available. From what we hear from partners in government, the supplies are incoming, but of course we have to take into consideration everything that's happening, and from experience, the supplies have not always been there when we needed them. But as we can see, that it is very much the supplies are very important, and unfortunately these supplies are not readily available, readily available as of now. Actually, sorry, I suddenly realized that I'm preempting tomorrow's lecture. Dr. Donna and Dr. Mian will be able to go into this in more detail. But Ma'am Mian or Ma'am Donna, do you want to add anything regarding this issue without touching in depth into it?
I think we'll take it up for tomorrow.
Okay.
Yes. Please hold that question together with a question from Shukriya. Shukriya had a very excellent question also, but I asked her to re-ask it tomorrow again. The question was, what is your recommendation for referral and treatment of the cleft patients with acute malnutrition, whether MAM or SAM? Does your threshold lower because of the fact of them having that inherent risk for acute malnutrition? So Shukriya and I were messaging each other that we would discuss that in greater detail tomorrow's open forum. So I hope we can hold that, and that's like a teaser for tomorrow.
I think, ma'am, actually most of the questions are jumping off. Actually, I think it indicates that they were listening because they're looking forward to what needs to be answered in the next lectures.
Yes. I see a lot of questions about the content tomorrow. And a lot of thank yous from many people that we know, even Barbara, and we'd like to acknowledge Barbara. I don't know how to say your last name, Barbara. I mentioned it as Delage earlier in my lecture, but I hope that wasn't butchering your name. Thank you for your input, and we feel that you should be on this panel for the open forum, but you had a question about where areas RUTF are not available. What are alternative commodities? I believe I cannot find the question anymore. But yes, please hold your questions for tomorrow. This is making us very exciting, very excited, and it's also hopefully it will also keep the others here with us tomorrow. Is there a pending question that we should resolve today rather than wait for tomorrow?
I think, ma'am, on the Q&A tab, we've covered everything, and I was trying to look through the chat, but I think we've covered a lot of it already.
Yes.
Most of the questions are for tomorrow's lecture. So we thank you for listening, because those are actually excellent questions, but we don't want to answer them right now because it will preempt what we will be discussing in the next lectures.
Yes, and we are very energized by the fact that people are asking these very difficult questions of implementation. I mean, it's all nice on paper, and yes, here we are with more and more of these babies identified to have SAM and MAM, but then the question remains, now what? So here is where all of us have to put our heads together for the now what, okay? It is 5:49.
Ma'am, there's just a quick question. There was a follow-up, may pahabol, sorry, I'm lacking the English word for it, but there's another
The
question here.
fishermen, okay.
Yes, ma'am. Not the fisherman, ma'am. This one is in the chat. It says, if the patient has a history of being an extremely low birth weight or premature at birth, do we interpret their anthropometric measurements differently versus a term with a normal weight at birth? From Eleanor Corte.
Okay. Oh, our neonatologist colleague, Eleanor Cuarte. Usually as neonatologists, our guide is that by 3 years of age, the growth and even development of preterm should have already caught up. No, so before 36 months, we still correct for age, but after 3 years of age, so the baby is still less than 5 years of age, they should be considered as with their age appropriate peers, with the growth standards for WHO. And we'd like to stress that we use the WHO child growth standards because the subjects in these standards are 100% breastfed, okay? So the growth charts that we grew up on in our baby books, okay, were from populations that included either mixed or exclusively formula-fed babies, and as such, those so-called norms were probably driving suboptimal breastfeeding. No, so but please, we do use now the WHO CGS growth curves because these have been derived from populations of exclusively breastfed babies all over the world, from both developing and developed countries. So I hope that may have answered Ellen's question. Ellen, unfortunately, we don't have the capacity in this webinar to give you the mics, no? Could I just answer quickly the question of Mary Villanueva on the fisher folk population? This isn't a direct answer to your question, but I was involved with a researcher who looked into feeding practices of fisher folk in her various populations. And what she found was very interesting, that the fishing practices of fisher folk families, no? The fishing practices proper of fisher folk families was driven by how they were feeding their infants. So the fisher folk that she interviewed, I believe it was in the coastal areas of Batangas, in southern Luzon, tended towards illegal and unsafe fishing practices like dynamite fishing. No, their artisanal fishing practices were driven by the need for income to purchase infant formula. No, so the impact on the environment of how fisher folk are feeding their infants, or how they think they should feed their infants, was actually driven by these economic pressures. No, so of course, it's not a direct answer to your question, but yes, both farmers and fisher folk practices are probably driven by what they think should be fed to their families. Over to you, Drew.
Yeah, thank you, Ma'am Ian. And just to add to that, it's basically also in terms of this is going a step ahead because we're looking at the treatment of children basically, but you have to also consider the context where they're coming from, because even if you rehabilitate these children, you get them back to normal basically, and you cure them from their malnutrition. If they end up going back to their routine environment where things may not be ideal, you definitely run the risk of these children relapsing and again becoming malnourished again. So we'll be discussing this more in more detail tomorrow. But the program looks at treatment on a more holistic level. Basically, it's not just looking at not just treating the physical manifestations of malnutrition, but also the societal parts as well, which is of course more easily said than done, but at least there's an attempt. And actually, as we will actually be going into some, we will be going into some examples tomorrow, and we can see that it can be done. There are positive steps that have been reached because of this program, and who knows, maybe even in the other countries as well. When you start, if you're doing your own program, I'm sure that there are other success stories waiting for us as well. So there we go. Yeah, I think most of our questions are preemptive, so I apologize for not being able to answer them. But we will take note of these questions on RUTF, on the treatment, and we will make sure to also highlight these questions tomorrow and during our lectures. So yeah, I think that's it. Dr. Ramian or Dr. Donna, is there anything else that you'd like to say to add? Yeah. So
Unfortunately, Donna's video is now functioning. So, but she's been able to talk, no? Donna,
Yes.
anything
Right, yeah.
else? Yes.
No, I'd like to thank Drew for such a comprehensive presentation on measurements online. Very difficult to do. And so, salute, Drew.
Yes. So
it underscores that we need to do face-to-face. Just kidding. Next time.
soon, yes. Soon, hopefully safely soon.
Yes.
For Nadine's question, what we don't want is that you use bathroom scales or non-digital infant scales even. So, but if your context does not allow you to purchase these Salter scales or height boards of your own, then there is always your local government health unit, no? Your municipal or city health office that by this time have purchased these standardized equipment. And I thought Kimi raised her hand to say that Smile Train would be providing partners with the standardized equipment, but I didn't want to put Kimi on the spot. Okay, but we can talk about other things like MUAC tapes, Kimi, maybe those are a little less, how do you say this, expensive.
Yes, and actually in these particular cases, it's more of putting things together, because there might be other people already working on this on the ground. So it's a perfect opportunity for collaboration. And like this particular webinar, actually, it's a very energizing opportunity for us. So we're very happy to be able to partner with Smile Train for this, and to even more engagements later on.
Yes, private-public partnership. Actually, private partnership. But no, we have a lot of Department of Health personnel here at the regional level. We'd like to say hello, shout out to you all, Ma'am Feli, who is Celia, Sel Palad is also here. No? Hello to all of you, you've been saying hello. Okay, it's getting late for...
Yes, so once again, we thank everybody. Actually, this first day is more of just an appetizer of sorts, an appetitis of sorts for our next few lectures. But we want to say thank you to our participants who have been here from the start. It's still we still have around 200 participants in the room, so thank you very much for staying. Thank you very much for your attention. It's as we were saying, this is a modified course and much better done face-to-face, but we really appreciate your engagement. It's been a very very lively discussion so far. Just to recap what we've done for today, we basically had a quick overview on both the problems of having cleft lip and cleft palate, and also for malnutrition that we've encountered separately as different organizations. But as we can see, our problems are aligned, and there are many things and many opportunities for us to be able to overlap and work together for better nutrition for our children. And even though signs are pointing over the past years, basically, for example, in the Philippines, it's been said that things are improving. Malnutrition should not be a problem anymore, but it's quite apparent that malnutrition still is a problem. And it's not something that's going to go away just in the blink of an eye. There's a lot more to be done, and it's incumbent on us to be able to still provide the proper treatment for these children, because basically we have to reach out to these children in the peripheries or the laylayan. Basically, these children are still in need, and we can't leave these children behind. And it's very nice to know that organizations like Smile Train are not just focused on problems for cleft lip and cleft palate, but they're looking at the comprehensive health and nutrition of these children, and which is very important for us to be able to move forward in improving the nutritional status of our children. And Dr. Donna was able to show us that to provide a quick and comprehensive overview of malnutrition, of the problem of malnutrition in our country, and what the problem is still there, but corollary to it is that there's actually a solution, and the solution is right here, right now in the Philippines, and it's something that is actually present in other countries as well. So it's a matter of us being able to maximize our resources, maximize our opportunities in order to be able to correctly identify our children, basically understanding the fundamentals and knowing how to properly identify children, so that in the next day, like for tomorrow, we will be going into lectures on knowing how to triage and refer children, and basically knowing where they, after identifying their nutritional status, knowing how to properly treat these children, whether they are 6 to 59 months of age, or for a particular interest, what happens to because we've been focusing on children who are 6 to 59 months, or basically under 5 years of age. But what about children who are less than 6 months of age, which in the Philippines has been a gap in the past couple of years, because there hasn't been very clear guidance on how to go about this. So these things will be discussed tomorrow, including techniques for the very, very important skill of counseling, which is as we have seen, actually, we will see tomorrow that this is a very important factor also as well in how we treat our children with malnutrition. So we thank everybody for their participation for today, and we look forward to tomorrow, and we hope that you will still be here tomorrow, and we look forward to discussing the lectures again, yes, we're very much excited for it. So thank you very much for your participation. We'll see you again tomorrow at 2 o'clock. 2 o'clock here in the Philippines, different time zones across different countries. But no matter, it's so encouraging to know that even though it really is a small world after all, and that we're all here together on this platform, because we all believe that there is a solution to this problem of malnutrition. So thank you very much to everybody. We'll see you again tomorrow. On behalf of Smile Train, on behalf of KMI, thank you to everybody behind the scenes, like Mr. Alvin De Gracia and Sir June and Sir Tompet. Thank you very much, and we will see you all again tomorrow. Thank you very much.
Thank you, Drew. Excellent. Thank you, everybody, for